Okay, so leading off our first session is Dr. Hua, who will be presenting on whether there's a role for photobiomodulation in non-neovascular AMD. Thanks, Dr. Hua, for being here.
All right, thanks for having me. You know what they say save the best for first. My name's Hongween Hua. I'm an adult and pediatric retina specialist at Bascom Palmer in Miami, and I did my fellowship at Coli, so thank you for having me back. Hopefully you guys don't regret it. And we'll be discussing whether or not photobiomodulation works for AMD. And AI was used to generate some images for this talk, but only with the program director's permission. And this is a photo of Dr. Retchitskaya using red light therapy, and now you know the secret behind all of her youthful glows. These are my financial disclosures, of which Alcon is relevant because they recently acquired Lumathera and the Valida light therapy, but this will be a fair and balanced talk. My goals are to discuss the mechanism of action of photobiomodulation for AMD and to review and interpret the clinical trial data, and also discuss the clinical benefits and significance of PBM for AMD. So how does photobiomodulation work? It was discovered in the 1960s by Ender Meister, who used low-level laser light therapy for wound healing and hair growth in rodents. The way it works is it modulates inflammation through light sources such as low-level laser or non-coherent LEDs, and it targets mitochondrial activity, specifically the enzyme cytochrome C oxidase, which is the photoacceptor of light in the far red to near infrared spectral range. And the mitochondrial energy typically regenerates ATP through replication, density, and increase RNA and protein synthesis. So it produces an antioxidant response, and in normal cells it can actually produce reactive oxidative species, but in oxidatively stressed cells, which is thought to be behind the pathophysiology of dry AMD, these ROS levels are lowered, and it can upregulate antioxidant defenses and reduce oxidative stress, but there's a biphasic dose response to this. So at low levels of light, it stimulates this activity. At high levels, it'll typically inhibit it. So I asked ChatGPT, what do you think? Does Valida light therapy system work for dry AMD? They told me, short answer, yes, with important caveats. So we're going to review the data together. I think the jury's still out. So let's review the studies. Raise your hand if you're a trainee. Okay, who can tell me the name of the clinical trials that led to the FDA authorization of Lumathera Valida light therapy? Good jobs. Don't worry, you don't have to sweat anymore. That's the only pimping that I'll do this session. So let's talk about LightSight 2. It was a smaller study that gave 3 doses of photobiomodulation, and these doses were separated by 4 months and consisted of 9 treatment sessions, so 9 in a span of 3 to 5 weeks. And it was a smaller study with 44 patients and 53 eyes. And in LightSight 3 was a larger study, had 6 doses of treatment, again, also 9 treatments within 3 to 5 weeks, punctuated by quarterly intervals. And I'll point out to you that the visual acuity criteria changed for LightSight 3. We'll discuss that a little bit later. The treatment group included photobiomodulation with spectral wavelengths of 590, 650, and 850 nanometers versus an active sham. So the sham was a reduced dose of light, so reduced dose of the 590 and 660, and also completely omitted the 850 nanometer wavelength, and then 9 sessions as over 3 to 5 weeks at a quarterly basis. And the endpoint for LightSight 3 was a best corrected visual acuity change from baseline to month 13 and 21. So the inclusion criteria, you have to be at least 50 years old, have a diagnosis of dry AMD as defined by Drusen or non-foveal central GA. And the visual acuity scores was between ETDRS letters of 50 and 75, which is a Snellen equivalent of 2032 to 2100. I just want to point out at large, the early and intermediate dry AMD population has an average best corrected visual acuity of 2025. So if we look at LightSight 2, there was a modest best corrected visual acuity gain of 2.3 letters, but with a large standard deviation. And with LightSight 3, we saw a larger jump, a larger improvement in visual acuity gain of 5.6 letters in the treatment group as compared to 1.3 letters at 24 months in the sham group. If you look at the line curve, the graph on the upper left, we can see that there is a separation of curves in terms of visual acuity gains, but it is only 2 to 4 letters difference in between the two groups. We can see that a larger proportion of the treatment group had a treatment response and had a higher baseline visual acuity. And that the patients who had lost visual acuity, a larger percentage of these patients were in the sham group. The percentage of incident geographic atrophy was higher in the sham group as compared to the PBM group, which was statistically significant, and there was lower drusen volume over time in the treatment group. And we can see this representative OCT of a patient that received PBM therapy that had decreased drusen burden while the EZ and the RPE stayed intact. So adverse events include typical dry eye. Also, most importantly, there was a higher percentage of conversion of AMD in the PBM group. However, they did note that at baseline, they had a higher proportion of high-risk eyes that could convert to AMD, and when they adjusted for this risk, both groups in theory had a similar rate of conversion to choroidal neovascularization. So in LightSight 2, there was concerns about drusen segmentation. In figure 4 of their paper, you can see that the light blue line does not exactly correlate with their drusen segmentation, calling into question how their methods worked. And then if we look at their baseline geographic area in the study, the sham group had larger baseline geographic atrophy. And if we look at figure 5 in their paper, they missed some areas of geographic atrophy in their autofluorescence photo. In LightSight 3, in their baseline cohort, the average age of the sham group was older than the treatment group. And then we also already mentioned the visual acuity inclusion criteria, which calls into the question, is there a regression to the mean in terms of these visual acuity gains? So why are there such small n's? Let's just review really quickly these pathways for medical devices. So the pathways for medical devices include pre-market approval, de novo classification, and 510 clearance, which is mostly used by similarity for different devices. In pre-market approval is typically for more high-risk devices and require more rigorous studies, and it calls for substantial evidence to prove its clinical efficacy. However, with de novo classification for lower risk medical devices, it only requires effectiveness and safety, and reasonable insurance, which may insinuate a smaller sample size for these studies, but statistically justified. So Velita light therapy came under the classification of de novo authorization, which explains why the N was smaller in these studies. So just for a matter of time, the summary of these different systematic reviews and meta-analyses looking at LightSight 1, 2, and 3 and other photobiomodulation therapies show, this one included some green light, that there is a trend towards visual acuity gains for PBM exposure, but it's not yet truly clinically significant when you summarize all of this data together. But when you look at secondary endpoints like drusen volume, geographic atrophy, there's no true difference. So these are the key takeaways, that the LightSight trial showed modest visual acuity gains versus sham. That LightSight 3 did show a reduction in drusen volume with decreased incidence in geographic atrophy progression. But there are some limitations. There are small sample sizes. The visual acuity improvement did not meet meaningful clinically important differences. So while it was statistically significant, it may not be clinically relevant because the Snellen line is 6.8 ET DRS letters. And so now that I've given you the data, and in this environment where 2 years with a discount is $6,500 and insurance isn't covering this treatment yet, raise your hand if you think that photobiomodulation is worth it. Or raise your hand if you don't think it's worth it. No one's committing. Okay, all right, you guys made the decision. Thank you to the Colai family for having me.
Thank you so much, Dr. Hua. We'll take 1 or 2 questions.
And there's microphones on the side that people can use. I have a quick question for you. So one of the comments that I've heard from a lot of colleagues in our retina community is that the people who are, some of the people who are using this treatment on their patients are giving the argument that they would rather be the ones to be able to utilize it rather than it falling in the hands of non-retina specialists. What are your thoughts on that? That if this is available, that it should stay within the retina community?
Yeah, I think that gets really messy. First of all, we don't know what's going on at the payer level yet. No one's really covering it. And then with scope of practice issues, I mean, I think the fact that there's not a lot of buy-in from the retina community makes it fall much wider into the question of who gets to deliver this therapy. And there are many optometrists and general ophthalmologists who see this as a revenue-producing therapy, which gets a little dicey.
So, Hong-Ween, great talk. I mean, one of the interesting things about this, that, again, it's so challenging interpreting this, but when, Glenn Jaffe showed the ellipsoid zone preservation data that goes along with this as well, it made me start to believe more that we really need a lot more data with it. And so it's an interesting piece. Are you guys looking at it at Bascom? And I am curious from the reimbursement side, as soon as it gets certain levels of authorizations, all of a sudden the landscape's going to change dramatically from the payer piece as well. I'd love to hear your thoughts on that.
At the Bascom level, we haven't really had buy-in as retina faculty, so there's no current plans for us to adopt it. And I think once payers start agreeing to pay for part of this therapy, I think you'll see much larger uptake at a patient level.
Thank you so much.
Awesome.
So our next talk is going to be by Dr. Dilraj Grewal on what's next in AMD and geographic atrophy therapy.
Thank you so much, and thank you so much, Kat and Phoebe, for the opportunity to be here with you today. So, as you fellows know, this is a very exciting time for retinal diseases, and there's a plethora of clinical trials in wet macular degeneration as well as GA. So broadly categorizing them into new molecules, TKIs, and gene therapy. So Kat's going to talk about gene therapy later on, and then Abdul's going to talk about TKIs. So I'll focus on the new molecules that are currently under investigation. And the first one that's exciting is the Wnt signaling pathway. And this is really a protein called neurin that binds to the endothelial cell receptor complex. And this includes proteins like FZD4, T-span, and LRP5. And the idea is that these are required for maintenance of an intact blood-retinal barrier. So in exudative diseases, there's some potential value of having a neurin mimetic or a Wnt agonist to help control exudation. And this is a molecule called Restoret, which was developed by iBio and is now been acquired by Merck, and was studied in a phase 1-2 trial called Amarone for DME and neovascular AMD, and was combined with aflibercept 2 milligrams. And the effect was favorable through week 12, and this is now being studied in a phase 2 study called Super Tuscan, where they're comparing 2 doses of this molecule as monotherapy, which is different, and then also as combination with aflibercept. The other molecule in the Merck family is a Tie2 VEGF bispecific antibody called Tispectus. And this again showed favorable results in an early phase 1/2A study called the RIOA study. And based on that is now going to advance into a phase 2B3 study called the Malbec study that's starting enrollment last month. And again, this is comparing 2 different regimens and comparing it to aflibercept 2 milligrams. The next molecule is tarcocimab, which is by Kodiak Biosciences. And this is a molecule that you may have heard of a few years ago, but the studies were unsuccessful because there was a higher rate of cataract formation, particularly in the diabetic population. But since then, they have reconjugated this biopolymer conjugate, and it has a different property which should hopefully reduce the risk of cataract formation. This was studied in a phase 2 trial, the DAZZLE study, where it was administered every 3 to 5 months as compared to on-label aflibercept 2 milligrams. So really a durability play, and actually was not successful. It was inferior to aflibercept in that study. So based on that, they have now conducting a phase 3 trial where there's variability in dosing regimen, and it can be administered all the way from Q4 weeks up to Q24 weeks. And in parallel, they're also studying another molecule, which is a VEGF trap and IL-6 antibody combination, again conjugated in the same proprietary mechanism. Plus the formulation of both of them is now different. Again, the active comparator in this study is 2 milligram of aflibercept, and the readout will be in Q3 of this year. And then finally, we'll also be looking forward to prefilled syringe with the 8 milligram of aflibercept to join the faricimab prefilled syringe. Now, what about some recent failures in the wet AMD space? So there was a bispecific molecule by Roche called Dutafab, which was bispecific for VEGF-A and Ang2. And this was actually being studied in their port delivery system as the next generation for the ranibizumab formulation. And this was recently discontinued based on the early results of the phase 1/2 Burgundy study. The other failure that you may have heard of last year was of Thea, which had a molecule that was blocking VEGF-C and D. So this was basically given in combination with your VEGF-A blockers, that is aflibercept or ranibizumab, and was designed as a superiority study, which are actually much harder to get through as compared to non-inferiority trials. So what about geographic atrophy? So the geographic atrophy, we are familiar now with the complement cascade and the established mechanism of both C3 as well as C5 inhibitors in the pathways to prevent RPE cell death and preserve photoreceptors. We also know that there's long-term data now from complement inhibition that demonstrates that there's a sustained and cumulative effect going all the way up to 5 years now with pegcetacoplan and 3.5 years with the ACP molecule. And again, these curves continue to diverge over time. So based on this, we now have 11 programs that are in active clinical trials as of last month. Several are in phase 3, and then others are earlier on the stage. But also important to remember that there have been more failures in the GA space than they have been in the wet AMD space. And again, it's a harder disease to control, and I still feel that complement is only one part of the story that we are focused on. Kat's going to speak about the gene therapy trials in geographic atrophy. That's also very exciting, and because it gets rid of a big problem with the current mechanism, which is the repeated injections with no potential end date. So what about the current phase 3 trials? So Regeneron has a phase 3 trial called the Sienna, which is testing a subcutaneous administration. And this has several advantages, particularly when we treat bilateral disease, subcutaneous administration potentially every 2 to 4 weeks has clear benefits over every month to 2 month bilateral injections. And this is testing, again, the C5 pathway. It's testing 2 molecules, pozelimab, which blocks cleavage of C5, and combined with or without cemdisiran that lowers the C5 levels. And they had a smaller, earlier phase study that had about 225 participants that is now enrolled, and now they're moving on to a larger global study with about 750 participants. Apellis is also conducting a phase 2 study where they're looking at a conjugated small interfering RNA, or an siRNA, that is targeting complement C3, so systemic C3 inhibition, and they're testing this in conjunction with administration of intravitreal pegcetacoplan. And this is also potentially promising because there's early data that this systemic administration subcutaneously can reduce your circulating C3 levels by up to 90%. Avicida just completed a phase 2b trial, and Avicida has a nanoparticle which has these polycyclic acid ligands that are present on the surface, and these interact with Siglec, which are basically sialic acid binding immunoglobulin-like lectins, and are basically designed to suppress activation of inflammatory cells. Now, they compared the study to monthly ACP and found no difference in the rate of change, but they did observe that there was a higher percentage of patients that had some improvement in vision, as well as a lower rate of conversion to neovascular AMD as composed to ACP. So they are proceeding with planning a phase 3 trial. Annexon is another player in the complement space that is targeting the C1q pathway, which is way higher up than the C3 and C5 pathways currently targeted. And their drug, womapropind, had some effect on RPE loss, mostly after 6 months of administration. So overall, while the reduction was not significant, they argue that the slopes diverge over time, and that's something that we continue to see with C3 and C5 inhibition as well. They demonstrate preservation of EZs, particularly in the central area, central 1.5 millimeters, where it's most important to vision, and again, a dose-dependent protection from vision loss. And based on this, they are now advancing into a phase 3 trial. And then finally, the last few seconds will be covering cell-based therapies for GA, and this is particularly exciting. So Lineage Therapeutics just completed a phase 1-2 study in which they looked at subretinal and suprachoroidal delivery of cell-based therapy. And what they found was that if you were able to achieve a good subretinal bleb, particularly in patients that had not very advanced GA, there was improvement in vision as well as the ELM. And they're working on proprietary injectors for subretinal as well as suprachoroidal delivery. Mark Humayun's regenerative patch technologies involves a membrane that is placed subretinally by creating a retinotomy. And the idea behind this is, again, to create a composite RPE cell membrane. And this has, again, shown some improvements in the early phase and is now advancing to a phase 2b study. So it's important, it's an exciting pipeline. I think we're going to really be forced to consider how we use these medications, how we monitor the treatments, and focus also on real-world data. Thank you.
Any questions for Dr. Graywall? Did you see any safety signals? I mean, do you know, and like the earlier, especially the cell-based studies, any safety signals at all in phase 1?
And not so far, but as you imagine, these patients are getting a pretty substantial amount of immunosuppression. And I think that's a lesson that we have learned from some of the other trials, gene therapy trials as well, that we really need to be aggressive with immunosuppression, both systemic as well as local.
Okay, great. Okay, thank you. Our next speaker is our illustrious co-chair, Dr. Catherine Talcott. She'll be speaking about gene therapy in AMD.
Awesome. Thank you. Here are my disclosures. So really in retina, we're so fortunate to, especially in the field of, in the subject matter of neovascular AMD, have so many different tools available in our toolbox to be able to treat patients. But unfortunately, the results that we see in clinical trials aren't replicated in the real world, where our real world use of anti-VEGF for neovascular AMD is unfortunately associated with poorer than expected visual outcomes over time. And this is in large part due to sort of under-treatment. And we recognize this as retina specialists. This is the ASRS PA2 surveys from 2025, showing that most of us as retina specialists feel like the greatest need in this field is agents with greater durability. And so, as Dilraj mentioned, and Hadi will mention later, there's a lot of things in the pipeline for neovascular AMD that have the potential to disrupt the treatment landscape, including some of the TKIs, and I'll talk about gene therapy during my talk. And then in addition to neovascular AMD, geographic atrophy is another disease state where we really need sort of better treatment. We're really lucky to have 2 different FDA-approved treatments, but these treatments involve intravitreal injections every month or 2, which is, can be cumbersome for patients. And gene therapy really has the potential to really change the landscape, and really that it prompts the eye to create a novel therapeutic protein or turn the eye into sort of a biofactory, and has the potential to be sort of a one-and-done treatment. So for the purposes of tonight's talk, I'll talk about just a really brief overview of some of the gene therapy treatments in the pipeline for neovascular AMD and GA. It's not meant to be exhaustive. I'll focus on the ones that are sort of closest to FDA approval. So gene therapy for retinal disease is really exciting overall. It utilizes AAV vectors to be able to enable, at least in this field of neovascular AMD VEGF suppression. It can be delivered intravitreal, subretinally, or suprachoroidally, and really allows cells to be able to create long-term intraocular expression of therapeutic proteins. And there's different options for being able to deliver these therapies that come with sort of pluses and minuses. Intravitreal gene therapy is really exciting because it can be done in clinic, but because it's injected into the eye, does have more of a safety concern in terms of exposure. Subretinal gene therapy is obviously a little bit more cumbersome in that you need to go to the OR, and it requires a procedure for the patient, but potentially the safety signal might be less with this as the gene therapy is delivered underneath the subretinal space. So I'm just going to talk first about neovascular AMD. RGX-314 is an AAV anti-VEGF Fab gene therapy that's being developed for neovascular AMD, and it's being investigated either being used underneath the retina or suprachoroidally. We have data from the phase 1/2 studies which showed stable to improved vision in these patients who are on this treatment and stable to improved anatomy with meaningful reductions in anti-VEGF injection burden. Here's just the overall current program status for this technology. The phase 2b/3 studies of Atmosphere and Ascent we're still waiting on results for. In the meantime, there's some information on fellow eye substudies and long-term follow-up studies for these patients. So this is just looking at the fellow eye substudy. These are patients who had one eye that were included in the phase 1/2a study or the phase 2 pharmacodynamic study, included 20 patients who had injections done in their sort of fellow eye. And these are patients who really required a lot of injections beforehand. And 78% of them were able to go injection-free following treatment. And you can see, as we kind of would expect with these patients who are controlled and then switched over, they had stable vision and anatomic findings. Ixo-vec is an intravitreal gene therapy, which is using a capsid to be able to deliver anti-VEGF aflibercept via a single intravitreal injection. It was studied in the phase 2 LUNA study. And you can see, which is a little different for these gene therapy studies versus some of the other technologies, is that there's a lot of corticosteroids that are given to these patients to suppress any potential inflammation. So the patients in these studies either receive sort of Durezol or the dexamethasone implant, plus or minus oral prednisone. And these patients also had a significant reduction in their injection burden, and 75% of them were able to just have 0 to 1 injection supplemental. And they were able to maintain sort of stable vision and CST as well. And it's going to be looked at in the phase 3 Artemis study. There's also the 4DMT, 4D like 150 intravitreal gene therapy that's encoding production of aflibercept as well as an RNAi that's blocking VEGF-C transcription, and it was examined in the phase 1/2 PRISM study. First looking at patients who really had a lot of disease burden, but the phase 2b study looked at a more broad population where patients just needed between 1 and 6 injection in the year prior to their involvement in the study. And in this phase 2b, so this broad population, actually 70% of them were able to go injection-free at 1 year, and also being able to maintain stable visual acuity and anatomy. So this is going to be looked at in the phase 3 Forefront studies. And so sort of changing gears and thinking about GA as well, Dilraj mentioned this really briefly, but J&J 18887 is a one-time intravitreal injection that's being looked at for the investigation of treatment of GA. And this is aimed at increasing the expression of CD59 to be able to inhibit the MAC complexes. It was studied in a phase 1 study including 17 patients, which showed a decreased growth rate of GA in these treated eyes. And the phase 2b Parasol study enrollment is complete, and we're waiting for data on that. Another agent is OCU 410, which is a subretinal gene therapy meant to deliver the RORA gene, so that would target lipid metabolism, inflammation, complement inhibition, and oxidative stress. This was studied in the phase 2 Armada study, looking at sort of safety and efficacy, which also showed a reduction in lesion size at 12 months in these patients. And their phase 3, which is looking to enroll 300 patients, is aimed to start enrollment in Q3 of this year. But as Dilraj sort of alluded to, it's really exciting to have potentially gene therapy of sort of one and done treatment, but there's some other special considerations that we could consider. It's really attractive to be able to address sort of under treatment for these patients, but there is a risk of inflammation that comes with this. As we know, gene therapy can lead to inflammation, and our long-term effects are less known. And these study patients really involve being on more long courses of steroids than we're sort of used to in our normal patients. And that can potentially mean more work for us. I mean, I can think of prescribing a patient Durezol and getting my chart messages that it's not covered. And I don't claim to be a uveitis specialist, so when I'm going to be seeing patients with these, I'm just going to refer them to Sneal and Sumit and others in our group to take care of. And then I think the other interesting thing is if these agents do come to market, what's the economic impact of this? What is insurance coverage going to look like? And how will these treatments impact the economics of an individual retina practice, whereas you might just do one treatment as opposed to, these are patients who we see pretty regularly. So just things to think about, but thank you for your attention.
Thank you. Are there questions from the audience for Dr. Talcott? I have a question. So regarding the prophylactic steroids for the intravitreal, mostly gene therapies, right? So not for the subretinal ones, right? Are there alternatives being considered, and are they really needed in a prolonged fashion? It's like there's a lot of research going on at ARVO right now on gene therapy-associated uveitis and how it could be modulated. So what are some of the things that are being implemented?
Yeah, a number of these trials really have different regimens that they're sort of examining. Obviously, given some of the safety signals that we're seeing in earlier gene therapies, I think everyone would like it to be sort of controlled. But a lot of patients in these studies with intravitreal gene therapy are on drops or having intravitreal dexamethasone implants for up to 3 months. And then there's some arms that are including like oral steroids as well. So I'm hoping that we'll get some more information about how those different arms within these studies do. That gives us information about how much steroids they're really going to need.
Okay, thank you.
Oh, sorry. Thank you. And our next speaker is going to be Dr. Justice Sailors, who's going to be talking about integrating AI insights into clinical workflow from imaging to intervention.
Thanks, Kat, and thanks for the invitation. I'm going to change gears from all these clinical trials that we've been hearing about. These are my financial disclosures. And so one of the big questions that we hear a lot is AI the answer? And I think the first time that I gave a talk somewhat like this was probably 6 years ago, and it looks very different today than what it did then. And really, I think the answer is it's probably going to affect us everywhere in the way that we touch patients, in the way that we look at our clinic workflow. More specifically, what I'm going to talk about is how we've experienced it at the Cleveland Clinic and how we may be seeing it in terms of it impacting patient care for the future. So specifically, certainly automated detection of disease, remote disease activity evaluation, looking at visit support services both for the patient and for the provider, enabling next generation disease interrogation, understanding diseases in a way that we can't currently, and really enhancing our current platforms. What do we use now and how can they actually be better using artificial intelligence, and potentially then moving towards precision medicine, pattern recognition, phenotype classification. So what about automated disease detection? This is probably the lowest hanging fruit. And we've seen that before. Diabetic retinopathy was really where this started in terms of looking at, in ophthalmology, being able to identify the disease. And it was shown that using AI models, it was as good or better than humans. And this led to the FDA clearance of the first AI-based diagnostic across medicine. And again, it's an exciting place for ophthalmology to be because we've led in a lot of these spaces. This utilizes software to essentially look at what is referable level diabetic retinopathy or more than mild. And we now have numerous research group and companies that are looking at this technology for using this for automated image analysis and deploying it into our clinical practices. And we now have multiple different systems that the FDA have cleared to be able to use this. We don't necessarily need to use it within ophthalmology. We can now put this into places like the emergency room, primary care, endocrinology, places where we're not actually getting those patients into our clinics and be able to use this in a rapid access way. And now these are actually robotic, where you need very little training to be able to implement this. We actually, in a really exciting way, have been able to deploy multiple cameras across our footprint just recently over the last few months. You get these reports of where they're being utilized, what the actual positive diagnosis rate is, and where we then moving these patients to. And currently, we're using it primarily within our clinics to be able to understand how we're seeing these patients through, but ultimately to be able to push this out into primary care and endocrine. What about disease surveillance and activity monitoring? This is also a really exciting opportunity, and this is how do we look at home-based disease surveillance. We now have FDA clearance for home-based OCT, which is actually using AI-enabled monitoring of what the approval is for hyperreflective spaces. We talk a lot about fluid. That's not actually what the approval is for, but we see essentially these fluid monitors. We can look at threshold assessment of when the disease hits the threshold that then sends a message to the provider's office to say we need to get these patients in for treatment. And as we look at more long-term therapies, things like gene therapy, having this type of technology available to know has something changed may actually be really, really helpful. What about patient encounter support? This is something that I don't think we necessarily thought about in the way that it may actually truly touch our practices in a tremendous way going forward. When we look at it for us, one of the first things that were deployed at the Cleveland Clinic is using this to help us with clinical documentation. And so we deployed Ambience Healthcare to actually use this for tracking what the physician's saying in the office and deploying that into the EMR. This had a dramatic impact on provider satisfaction, was actually utilized really across the enterprise, except in ophthalmology, where I think our adoption was actually very, very low. Sumit can probably tell me better than I know. My guess is maybe we have one provider, if that, who's using it because we're too fast. And I don't have the time to dial on my phone to actually, by the time I get on, I'm already done. And so at the same time, this is still going to likely have a much more dramatic impact as it gets better and better, but it's clearly impacted the way we look at healthcare delivery. Similarly, how do we actually take patients' history? This will likely change very much over the next 5 to 10 years, where you have sort of a large language model that's actually doing the intake for the patient, maybe a robot that's transporting them to the room instead of a human. Sunil and I have already had conversations of where we're going to put the robots at Cole. So What about next generation disease interrogation and biomarker assessment? This is what's really near and dear to my heart, and I think what's particularly exciting in understanding our patients and the diseases in front of us. So ultra-wide field angiography is really one of these places where we can redefine the disease profiles that we look at. This is work that we did several years ago, looking at being able to actually quantify leakage and profile patients, and now we know that this may be the most important biomarker in disease progression in diabetic retinopathy, and perhaps one of the most sensitive indicators of disease activity in uveitis. So how can we use AI? Well, instead of just measuring this with traditional image processing techniques, now we can actually identify the nerve, the region of interest, the eyelids that need to be removed from it. We can look at multiple different modalities. We can look at the retinal vessels in ways that take just minutes to be able to do. And we now know that we can use these in clinical trial settings. We don't have to look at this and just say, wow, this patient got a lot better. We can actually quantify this and say that they went from a 25% amount of leakage down to 3%. And as we look at precision medicine, with the amount of patients and the amount of therapeutics that we're going to have, how do we better characterize this? And this is the type of technology that may help us enable this. So one question was, could we do this in real time? And using this actually with Charlie Wyckoff's group and Retina Consultants of Texas, we're actually able to do this where they were remote in Houston, taking these ultra-wide field angiograms that were sent to us in Cleveland. Within an hour, we had the results back to them to make a decision on whether or not to treat based solely on leakage index or their DRSS score, showing that we could actually utilize this as a clear treatment indicator. Lastly, what about OCT? So again, I talked about fluid. It's one of the low-hanging fruits, but really looking at the outer retina and being able to do compartmental assessment and understanding what this may hold for us is really, really important. One of the things that we've learned a tremendous amount about is that plaquenil toxicity is a much higher finding than what we initially thought. I mean, when I was in residency, we were doing fundus photos and just visual fields looking for bullseye maculopathy. Now it's all based on OCT. But even then, it's really hard to detect subtle disease unless you have a map that looks like this that tells you already have a bullseye maculopathy just because of ellipsoid zone loss. And if we could actually put this into rheumatology, and we're working towards actually deploying this within our EMR, deployed to be able to do an automated report to essentially alert who should be sent. And again, the initial plan would be abnormal versus normal, to be able to sort of understand how we can put this into clinical practice. AMD obviously is another opportunity. We now know that the FDA has said losing photoreceptors matters, and the way that we measure that is with ellipsoid zone loss on OCT. And so when we look at this, not all drusen are clearly created equal, and this is one of the things that we want to understand, everything from photobiomodulation to what we're looking at in new therapeutics. You know, we look here at this drusen map here, and overall the ellipsoid zone integrity, where green is normal, looks pretty much perfect. Over the course of 2 years, there's really minimal change. Here, that's about the same amount of drusen, but a dramatic impact where we see in the pink and the blue significant ellipsoid zone loss, and within 2 years, we see atrophy developing. That's the patient who you want in a clinical trial to understand impact. So how do we actually move this to point of care? And we get this question a lot. Well, the idea is to really have these type of visualization systems, and this was done from several of the team members on my lab, working towards being able to deploy this in front of clinicians and in front of patients to be able to look at everything from hypertransmission to on-phos maps to be able to understand which patients should we be treating earlier on. So in conclusion, really AI-enabled technologies are going to really impact probably every single aspect of care delivery within healthcare. Future state will likely include large language model integration, agentic AI, platforms for patient intake, initial evaluation. Home-based diagnostics may play more of a role. We need to understand the logistics around that, the reimbursements around that. And really what we hope for is a more precision therapeutic design for the way that we take care of our patients, something that models more off oncology, where we understand what treatment should we be doing to get the really best outcomes for our patients. And I want to acknowledge my team, and thank you again for your attention.
Great talk, Justice. Any questions for?
Justice, great work top to bottom. So, we've also been interested in automated diabetic retinopathy screening, and we've, put this out into primary care. It becomes like a paradox, though, like, you are creating value by getting this to the patient, but they're not coming to see you in the clinic. How do you guys, balance that? Is the gains for opening slots in your clinic versus seeing the patient where you can do, 10 other pictures instead?
Yeah.
How do you look at that?
So there's, I think, a number of ways. If I want to look at it from the public health side, most of those patients aren't getting to us. And I think that's the critical piece of it, is that there's a huge number. I mean, we looked at our backlog of consults for diabetic screening, and we weren't getting them in. This allows that point-of-care assessment. If you look at it from the operations side and the money side of it, we also have realized that there's opportunities to use that for a quick touch point and actually convert it to an E&M and actually have them talk to the physician about what was found and set up the next visit as well. So I think there's a balance that you can strike with it as well.
Do I have time for one more question? Justice, I'm wondering, do you think there's a role for automated analysis in patients being treated for GA with a current complement inhibition to kind of predict whether their treatment is effective or not compared to what would be expected?
So you're asking somebody who's incredibly biased. So I think there's two aspects of that, Alex. So one is, should we be using it to identify the patients who we should treat? And I think that's a huge gap that we have right now, is understanding who we should be treating and who we shouldn't. And I think having this type of automated analysis to understand, for example, the photoreceptor loss excess, the EZ loss excess would be hugely helpful. What we don't have yet are the predictive models to say, had you not been treated, this is where you would be in 18 months. And I think that's the part that would be also hugely helpful. And even, I mean, in the end, the patients who are 20/20 are those people who we probably should be treating, and those are the ones that are really hard to put in to the treatment paradigm. But if we knew in 2 years they wouldn't be driving, it would be super helpful to know that. So,
Thank you so much.
Thank you. Our next speaker is Dr. Rishi Singh, who will be presenting on dual mechanism versus high-dose anti-VEGF treatment for AMD, DME, and RVO.
Thank you. Thank you to Phoebe, Kat, and Alexandra to invite me to the program. I'm going to talk about all of these drugs and sort of the real-world analyses. These are kind of helpful. Obviously, we have the pivotal trials, but we obviously use them in practice, and it's good to see the same kind of outputs here, my financial disclosures for the presentation. So 20 years go by. Sunil, what's a 20-year anniversary gift?
For you?
No, for your wife.
For my wife, it's always the same. A dinner out, pizza.
No, it's China. It's China. We're here in the 20th anniversary of all these drugs. When I was a fellow, we started injecting these drugs. It's been amazing to have a drug around for 20 years and really to be as effective as it was day one. But we know, obviously, from Kat's slides that she presented, that there's obviously opportunity to do better. We have these new drugs out there now, aflibercept 8 milligrams, ranibizumab port delivery system, and faricimab, all approved for all these indications. And obviously, they differ in their clinical doses, and they differ in their size and molecular weights. But how do they differ as far as how they've seen in practice and what we're seeing in our patients as well? First and foremost, they have different molecular targets. Aflibercept 8 milligram has both placental-like growth factor as well as VEGF-A, while faricimab has both VEGF-A and Ang-2. And there's a lot of good preclinical data to follow on this information. But first and foremost, I think the important thing to tell you is that all these second-generation anti-VEGF agents really have higher molar doses. For example, Lucentis, the molar dose is 10 nanomoles, which is what we've typically had in our patients for many, many years. But faricimab has a 40 nanomolar dosage, and aflibercept 8 milligrams has a 70 nanomolar dosage. So they're higher molar dosages. It's not the dosage that's present here. That's actually the milligram dosage of the drug. So very important to know that there's a difference in the molar dose of VEGF-A inhibition and what you're giving, and that's higher molar doses have been shown to be beneficial in a lot of patient populations. And this is just one of those simulations that was completed a while ago in this kind of a model eye that showed that basically if you had higher molar doses, that there is a reduced clearance of the drug by about 34%, which means that there's a 6 to 9 week extension period potentially on higher molar dose in these patient populations. So let's focus on 8 milligrams of aflibercept. This is given in a 70 microliter injection. It's 4 times a molar dose of 2 milligram aflibercept, which is again at 70 nanomolars of total VEGF inhibition. And what you can see in this analysis, which is called the Illuminate study, which is an analysis of the IRIS registry, is they followed both neovascular AMD patients and diabetic macular edema patients, both who were treatment naive and switched from aflibercept 2 milligrams to 8 milligrams. They had to have at least 6 months of treatment. So that was an important aspect of the study that was followed in the switcher patients. Obviously, treatment naives were naives at the time of entry, and they followed the patients for change in visual acuity. Here are the baseline characteristics. I think the important point here is that the treatment naive had worse vision, which is what we sort of expect in the population. The switcher patients had better vision, but each of them had pretty equivalently, not great vision in this population, about 20/60, 20/70 vision on entry for this group of patients. What we saw in the study was on the top, you see the neovascular AMD patients that the change from baseline to index date for those patients who are treatment naive in the 20, 50 or worse population, they gained about 4 letters. And you look at the patients in the DME trial, they gained about 5 letters if they're treatment naive, if they're 20, 50 or worse. 20, 50 or better, obviously, they had a little ceiling effect. There was just an equivalence or stability of visual acuity. On the left side, you see actually what was kind of really interesting to see, which is their last frequency of injection interval, which you see is about 12 weeks for those in neovascular AMD patients and 11.7 weeks in the DME patients. So quite a great extension period of time we saw with these patients. And if you actually tier this out in the prior treated patient populations, on the bottom you see all the pre-switch injection interval subgroups, and what you can see essentially is that for each of these subgroups, that the patients who had the most frequent injections before switching actually had a nice 2 to 3 to 4 week extension period after switching for both neovascular AMD and for diabetic macular edema. So in conclusion, we've seen this in multiple other studies. These are all the studies that have been done in the past. These are smaller trials, but again, show kind of similar results, which is that there's an improved OCT anatomy, but also stability or improvement, or slight improvement in visual acuity across these patient populations overall. Let's switch to looking at faricimab. Again, a different molar dose for VEGF-A, but again, anti-Ang2, which is a newer target that we're looking at for our patient populations, an anti-VEGF bound to a modified FC fragment in these patient populations. We've seen really great biomarker data, and this talk would be too long if I went into all the biomarker data on both inflammation, fibrosis, and vascular leakage, which has been seen in the sub-studies of the larger trials that were completed. So we'll look a little bit at the real-world data, and this was a study called the FAR Retina study, which I've been a part of since the beginning. But this used, again, the IRIS registry and followed now patients over a 2-year period, and we can show you the 2-year data now for both neovascular AMD and diabetic macular edema. In this patient population for neovascular AMD, when we followed them over 24 months, the majority of patients were stable in vision on the left side for treatment-naive populations. And on the right side, the prior treated patients were also visually stable after 2 years of treatment. Now, you might wonder, that doesn't seem very exciting. Well, you have to take into account here that 51% of patients were 20, 40 or better on entry. So patients had a very good vision on entry for these populations of patients looked at in the IRIS registry, so they weren't expected to improve a lot. And again, we don't do protocol refractions as part of real-world studies, and so we might have missed some slight improvements in visual acuity in these patient populations. In the diabetic macular edema patients, you see the same story, except a little bit different than treatment-naive patients. You see about a 5-letter improvement in visual acuity. On the prior treated patient population, see equivalence of visual acuity in those patients as well. Again, 46% of patients were 20, 40 or better in these patient populations. One of the big advantages of IRIS is you actually can follow anatomy in a sub-study of those patient populations, and it was followed for those patients here. And you can see that the central subfield thickness improved in both the neovascular AMD patients and the previously treated and naive patient populations, and also in the diabetic macular edema patients at 24 months as well. So you see a nice anatomical improvement. And then looking at those injection frequencies over 6-month intervals of time, the frequency goes down, which shows, again, durability in the patient populations, which again was seen across the board in both treatment-naive and prior treated populations, both for neovascular AMD and in diabetic macular edema. Endophthalmitis and IOI were looked at. Again, very low rates of both of these situations in our patient population. So again, it's good to see this because we see not a signal on inflammation and concerns over both inflammation and endophthalmitis in these patient populations over time. There's lots of other sub-studies. I'm not going to go into those. They're all here. You certainly can get these slides afterward. I'm sure they're going to archive these, but you can look at them and follow them, but similar results across the board. Let's finish up with retinal vein occlusion and just show you some of the results. They looked at both the branch retinal vein occlusion and the central vein occlusion cohort in the IRIS registry as well. They saw improvements in visual acuity in the treatment-naive populations for both of these studies, for both CRVO and BRVO. The prior treated patients had stability of vision. This was a 12-month study for those in the IRIS registry. More importantly, 80% of patients were able to maintain or exceed baseline visual acuity, which I think again shows you the durability and the benefit of faricimab in these patient populations over time for both BRVOs and CRVOs. And again, looking at the anatomical thickness, you saw good anatomical improvement both in BRVOs and CRVOs, regardless of whether they're treatment naive or previously treated in these patient populations over time. Just to tell you the extension, because we're running out of time, but just to show you after 6 months of faricimab treatment, in the last 6 months of treatment, I should say, there was about a 10-day extension in the BRVO cohort and about an 8-day extension in the CRVO cohort as well. IOI rates were really low, endophthalmitis rates really low, again, not showing a significant safety interval as well. Let me finish on this slide, which is the limitation of real-world analysis. I love doing real-world analysis, but they're full of lots of problems. First is selection bias. Who would get switched? Obviously, these are the worst sometimes populations. These are not the ideal patients. There's no entry criteria to this. It's all patients who come into this. There's no control group. So if we treated, for example, with 2 milligrams of aflibercept, would we got the same result? The answer is possibly. There could be something like regression to the mean in these patient populations. Obviously, there's heterogeneity prior treatment exposure. We may not be giving the drug as frequently as we should. And hence, when we switch these patients, we sometimes do loading doses or things like that to improve that as well. These are short follow-ups. So again, for 8 milligrams, we're probably the shortest follow-up. But for some of the first-time studies, we have longer follow-ups in these patients. And lastly, survivorship and attrition bias, because many of these patients are lost after a period of time. We carry their results forward. It's not always the most statistically sound way of doing it, but that's how we analyze these patients right now. So thank you very much for your attention.
Great talk, Rishi. Any questions for Rishi? I have a quick question. Yep. So one of the things that you mentioned is, just the bias of who gets switched to these patients. And I think a lot of us as retina specialists will often switch it over our recalcitrant patients over. How do you see then the adoption of other therapies like gene therapy, some of the molecules that Dilraj mentioned, and the TKIs that might not have better drying? How's that going to look when sort of in real-world studies?
Pretty poor. I mean, that's the problem. I mean, I think if we had an ideal real-world study, we would all think about the entry criteria, the prior number of injections we should give. We probably should give them an injection within a period of time prior to switching them, which is important. We have not established that. I think we have established some really good definitions of non-response. Mm-hmm. Less than 10% decrease in central subfield thickness or a 5-letter improvement in visual acuity is really considered quote-unquote clinical non-response across many different studies, but otherwise it's really going to be hard to look at anything like that in these populations.
Awesome.
Thanks.
Thank you.
Yep.
So our last speaker is Prithvi Mruthyunjaya, who's going to be giving us an ocular oncology update. Thanks, Prithvi.
Thank you very much to my friends and colleagues from the Cole Eye Institute for putting together yet another great Retina Summit. I am a PI in all the trials that we'll be talking about and a consultant to the relevant companies. So a pre-test for the audience, and I am lucky to have 3 of my most favorite fellows who are also happen to be on the panel here today as well. So I'm going to ask direct questions. Right. So first question, Phoebe Lynn, can you name one landmark prospective randomized clinical trial in any eye cancer out there?
Oh gosh. Yeah, COMS.
COMS study, very good.
Yeah, COMS.
She's awesome. Justice Ehlers, when was the last publication year of said trial? You can go by decade, that's fine.
Decade?
Yeah.
1990s.
Very good. Sumit Sharma, can you name any other clinical trial in ocular oncology? Any other trial?
Comes to.
Comes to. The revenge. So the current state of affairs is that a patient unfortunately comes into your clinic and you see them with this large tumor, collar-shaped elevation. You're worried about an ocular melanoma. We do systemic screening. We thankfully find out that they are unlikely to have metastatic disease at the time of presentation. And then we move towards definitive eye treatment. And at that time, we're performing fine needle aspiration biopsies to do prognostic testing. And we know that the recent reports from the Collaborative Ocular Oncology Group, Report 2, tells us that a combination of gene expression profile testing and PRAME antigen detection gives us the highest ability to predict the risk of metastatic disease. And patients have really 2 options. Enucleation works 100% of the time, and radiation also works very well to treat the local tumor. But the story unfortunately continues. So the tumor is treated, the patient is screened, and we know that there's an unacceptably high rate within a few years of patients developing metastatic disease. And at that point, we have to think about treatments that are available, but unfortunately, patients rarely may survive past a year. The good news is that there are now, within the past 3 years, 2 approved treatments for patients with metastatic uveal melanoma in specific. The first is tebentafusp, which is a novel first-in-class bispecific T-cell redirection therapy in which the Drug is then attached to GP100 moieties on the surface of the metastatic liver tumor, and it attracts T cells to come to it, so a special form of immunotherapy. In patients that have predominant liver-dominant disease, there's melphalan infusion that goes directly to the liver and is filtered out with a special filter by the Del-Cath system. So back to the collaborative ocular melanoma study, which last published in 2006, very good. So three studies looking at small melanomas that were observed, medium-sized melanomas that were randomized to enucleation or radiation therapy, and large melanomas that were enucleated or given pre-enucleation radiation therapy. And that's led to the current paradigm for patients with uveal melanoma. Small melanomas are usually observed, sometimes irradiated. Medium melanomas get radiation therapy, and large melanomas are enucleated without radiation. But there are problems. If you observe small melanomas, maybe you're delaying treatment. If you treat them with radiation, there's going to be radiation retinopathy and vision loss. And if you remove an eye, you've lost the eye. So that's not always the best option. So let's look at some new ways to think about how we can treat these patients. So the CALM study said for a small choroidal melanoma, let's observe. Many of us now are thinking about earlier treatments or radiation treatment with the risk of vision loss. There's a clinical trial, though, called the COMPASS trial, which is a phase 3 study of belzupacap sartalocan, which is also called Belsar, by a company called Aura Biosciences. So this is a novel, again, first in cancer, virus-like drug conjugate. So it's taken an inactivated human papillomavirus, attaching a cytotoxic drug payload, and that's delivered to the target organ, and it attaches to heparin sulfate proteoglycan moieties on the surface of the tumor. This is now delivered through a suprachoroidal delivery and activated with a PDT-like system, and with two mechanisms of action. One is directly attaching to the tumor and direct tumor death, and then also T-cell activation to provide more of a memory to prevent future recurrence. So this has been used in a clinical trial now for small choroidal melanomas, and the phase 2 studies at the highest treatment dose shows an 89% tumor control at 10 months, and 88% of patients retained vision at 9 months. The COMPASS phase 3 trial is ongoing. That's looking at low, high, and sham treatments for these patients, and it's approaching its recruitment target. And this may be a radiation-sparing option for patients with small melanomas. So if we're looking at a new treatment options for patients, so maybe we can think of Belsar, but what about for the medium and large tumors? And this is reflected by a patient that I had in my clinic. So a 74-year-old woman who comes in with vision loss in her right eye. Her left eye is severely amblyopic. She's 2500 in her left eye, and her right eye has a large choroidal melanoma. Hand motion vision, 13 millimeters elevation and thickness. Just think about what her options are for this patient. So this brings us to the concept of neoadjuvant chemotherapy to shrink tumors. So I have a tumor in my eye. I can either treat it, and in this case maybe take the eye out, or you can give either local or systemic chemotherapy to try to shrink the tumor down to a point where you can preserve the organ. So that large tumor that was going to get enucleated, maybe it becomes smaller, and then you can treat it with radiation therapy. So definitive eye therapy can be performed. The tumor is treated, and since that drug that shrunk the tumor in the eye was effective in the neoadjuvant setting, you can give that same drug to the patient in the post-treatment or adjuvant setting to reduce the risk of developing metastasis, which is what will ultimately harm and kill the patient. So there's a drug called darovasertib, which is a protein kinase C inhibitor, and this works downstream from the main initiating mutations that we see in uveal melanoma, the GNAQ and GNA11 pathways, and this is found to be effective in the metastatic setting. So interestingly, during the trials to treat metastatic uveal melanoma, some patients hadn't had their ocular tumor treated. And when they're imaging these patients as part of the trial, they found that the tumors in the eyes got smaller as they were treating the tumors in the liver. So they thought, maybe there's something about local activity. So in a phase 2 Optum trial performed by the company called IDEA, these were eyes that were going to undergo enucleation. They were given the drug systemically, and what they found was that they were able to preserve eyes that were going to enucleation close to about 60% of them. And in those patients with the dotted line, which is 20% reduction in the size of the tumor, they were able to preserve 95% of those eyes. So those would have been enucleated, and then they could be treated with radiation therapy. If we look at the cohort of patients that were going to get plaque brachytherapy, they were able to reduce the size of some of those, which meant that those were patients that were getting less high doses of radiation to critical vision structures. And the thought is that we may be able to prevent severe vision loss. So here's my patient, hand motion vision. After 1 cycle, 20/70. After 5 cycles, 20/40, we treat her with radiation, we've saved her eye and potentially made an impact on her overall well-being. So now there may be a new paradigm to think about. So small tumors may get local viral-like particles delivered with a PDT treatment, and maybe we think about neoadjuvant treatment, and both of these drugs are in clinical trial. I'll just end because we know that radiation retinopathy affects so many of our patients that are getting radiation therapy either with plaque or proton beam therapy. The DRCR protocol AL looks at patients receiving plaque brachytherapy and randomizing patients to either faricimab, a steroid ILUVIEN implant, or observation, and looking at 3-year visual outcomes as a way to preserve vision and to save the eye. So if we're thinking about an era beyond the COMS trial, we have now new approaches to save lives, eyes, and vision. We're working much more closely with our medical oncologists to treat our patients, and ultimately I think this does offer hope for our patients into the future. Thank you.
That was a fantastic talk. Are there any questions from the audience for Dr. Mruthyunjaya?
Prithvi, I mean, it's amazing the progress that's there. I'm curious, obviously the molecular understanding of melanoma has had a big impact on how quickly you treat. Do you see that expanding in terms of more genetic profiling for actually even more specific targeted therapies as well?
Good question. You who led some of the early papers on genetic understandings in melanoma, I think that the genetics are really well understood. What our group is interested in is, are there other ways to define what is a high risk or low risk melanoma? We're interested in proteins rather than genes. And I think that has the opportunity to really look at very precise precision medicine models for treatment. And I think many groups are working towards that.
I think I saw someone getting up with a question.
Thank you for the talk. From my understanding, there can be some ambiguity in cases of what are described as small choroidal melanomas, where there may be, they may actually represent just a choroidal nevus. I was wondering what your thoughts were on the role of observation prior to initiating something like Belsar to see if you can assess for growth to distinguish those.
Really good question, and it's a active, ongoing area of clinical debate. The nice thing about the trial is that it did require not only a certain size, but also documented growth at a certain rate or velocity. So this trial has actually been hard to recruit because we see a lot of lesions that really may not change for a long period of time. So this is trying to look at those that are growing at the rate of a small melanoma, but you're absolutely correct. I think that you don't need to treat every one of these that ends up in your clinic. That's one of the risks of this type of drug, is that could it be overused? So I think better defining that, and maybe there are molecular ways to do that in the future rather than just trusting photographs or clinical features. Good question.
All right, so our first speaker of the next session is Dr. Sumit Sharma. He's going to be talking to us about surgical innovation in vitreoretinal surgery.
Great, thank you. My disclosures are as listed. The ones in red are potentially relevant, and I used AI to change the look of the slides. And so I'm going to go over a few things today. I want to talk about what's changed in the last few years in the vitreoretinal surgical OR. So we're going to talk about platforms, surgical imaging, surgical visualization systems, and what's on the horizon and what's coming in the future. So talking about platforms, if we look back at the history of vitreoretinal surgery, we've come a long way from Dr. Mockmer's first 17-gauge rotary cutter to now having a 30K cutter, and some robotic systems potentially coming down the pipeline. And the innovation has really shifted in the last few years to the surgical platforms, how we visualize, and how we look at intraoperative data. So we've gone from the last 30 years, from Accurus at an 1,800 cut rate initially to now the Unity at the 30,000 cut rate. And 27 gauge potentially has some use. So I use it in my complex tractional retinal detachment patients where you can use the new 27 gauge cutter that may have rigidity approaching that of a 25 gauge, especially in the Unity. And so in the Unity, we know that this is the newest platform from Alcon, and this has gotten up to 30,000 cuts per minute. And it's just a video from one of our fellows using the Unity. But what it lets you do, it has some interesting things. It has dual pumps, so it's dual fluidics, both peristaltic as well as venturi, and potentially gives you the ability to do things like flow control vitrectomy, which we didn't have before. There's also this interesting new tetraspot laser. I'm not sure at this time what the utility is, but it does look cool, and it looks like it's potentially faster. It's fun to use for those who've used it. But you can see it here, the 4-spot laser, where you're delivering 4 spots all at the same time. And then they also have their new Unify gas delivery platform. But what about the other companies? And so Dork has their EVA Nexus, that's up to 20,000 cut rate. Bausch & Lomb has a Stellaris Elite, that's up to now 25,000 cuts based on the newest update. And then BVI is a new entrant, approved in Europe at this point, but FDA approval is still pending. And it is also a dual fluidics system where it has both flow, allows you to do flow control with both a venturi and a peristaltic pump system. And so it has some interesting things. What about in imaging? Well, intraoperative OCT has really advanced in the last decade, and Dr. Ehlers and others have done a lot of work in this space. So when we go into clinic, we know that imaging is essential. We wouldn't dare go into retina clinic nowadays without an OCT, often without other imaging, including photos, fluorescein angiography, and ICG in a uveitis clinic or in an oncology clinic. So why do we do it in the operating room? And Dr. Ehlers, with the Discover study 3 years results, showed that nearly half, or about 43% of membrane peels, had a surgical decision changed by having intraoperative OCT, including 1 out of 8 patients that had an occult residual membrane that wasn't recognized by the surgeon initially. And so it really does allow you to change management in a few different places. And if we go through and actually look at the data, we can see some interesting things, because the intraoperative OCT in macular surgery definitely seemed to make a difference, and this is a survey of the surgeon after the case using intraoperative OCT in every single one of these cases, and then they had to gauge whether the intraoperative OCT either provided value in blue or if it changed their decisions in orange. And you can see for macular surgery, 60% of the time it provides value, 43% of the time it changes decisions. In complex detachments, 1 out of 4 almost patients have a change in management based on seeing things with the intraoperative OCT. But we haven't taken that next step, and the next step is how do we use some of the things that we're learning in the operating room based on what we're seeing happening with intraoperative OCT and really change our surgical management. And Rajiv Mooney has been doing some work in this space of why does the retina slip, how does it slip, and Dr. Ehlers has shown that with PFO in the eye, it's not what we thought. It's not that you completely flatten the retina. There's still residual subretinal fluid in most of those cases, and so we need to take that next step. But the other thing that intraoperative OCT does is it enables therapeutic delivery. And so for both subretinal blood delivery as well as subretinal TPA, and then Dr. Srivastava and I have used this for scleral window depth and to understand how deep to make your scleral windows so that you're getting a significant amount of the sclera out, but not going either too deep or too shallow to not get the effect that you're looking for in a uveal effusion syndrome patient. Well, what about 3D heads-up surgery? We have 4 different platforms, the Alcon Ingenuity, the Zeiss Artivo 800, the Bausch & Lomb C-Luma, and the Bayonix 1, and each of these has differences. And there was an interest in terms of what do these things add for you? And they add a few different things. But there was a randomized trial that looked at, not randomized, there was a clinical trial that looked at what happens. And so we found equivalent results for comparing a standard scope versus 3D heads-up system, but there was ergonomic gains, but there's some significant trade-offs. while it lets you use lower endo-illumination levels with the heads-up display system, the ease of use and peel times are faster with the standard operating microscope, especially early on, because there's a significant learning curve. And then there's some other trade-offs that I'm going to talk about in a second, but what do you get as benefits? Well, you can actually overlay the machine data. And you can see on the sides there, you're actually seeing what's happening with the vacuum, what's happening with infusion, what's happening with intraocular pressure as you're doing these various maneuvers in the eye. And with the heads-up display, you can actually also add, with some of these systems, the ability to see the intraoperative OCT directly on the HUD. And so I think it adds value in different ways. We still have to figure out where. It's definitely beneficial in trainee education. It lets you use lower illumination levels, and using custom color profiles, you can highlight certain things as well as enhance your depth perception. And it makes for pretty 3D videos if you're presenting, especially with 3D glasses. But there's still times where the standard operating microscope is better. The headgear and the machine positioning is challenging. The glasses can fog up or get forgotten to be put on before you scrub in. The headset for one of the systems can cause neck pain. You've got to kind of position everything in the operating room. There was, in the first generation system, significant lag with anterior work, and this has gotten much, much better, and it's down to a much more reasonable level. But there are still issues with color and saturation, where you can actually have oversaturation, and you can miss some of the subtle earlier clues. And then peripheral views are more challenging. I find the peripheral work with the 3D systems pretty challenging, and then specifically when you're using the laser beam, it can be really, really hard to see the aiming beam, and so it can be a little challenge to know where you're treating. And I want to finish with some of the things that are on the horizon. So robotic systems, where you actually are using a robotic system to reduce tremor, give you microliter level bleb control. It's right now a precision adjunct and not a primary tool. The Prima implant was in the news last year, and the Prima implant showed reading level letter recognition in some patients. And so that will be coming to our operating rooms. And then how about automated AI analytics? This is some of the work that we're doing that allow you to automated manner track surgical efficiency. And then RPE and photoreceptor grafts are also coming, and these are surgically implanted in the subretinal space, and it will possibly need robotic delivery. Intraoperative OCT will really help in this space, but I think overall, the platforms have improved. Intraoperative OCT helps. 3D HUD is real, but there's trade-offs, and for subretinal delivery, it's a major thing, but there's a cost, and each of these platforms have a cost that the standard scope doesn't, so you just have to figure out where that value lies for you. Thank you.
Thank you. We have time for a question or two from the audience or panel.
I have a question. What AI system are you using to make your PowerPoint slides?
Put it in the front.
Claude?
It was Claude and
Claude.
AI too.
Okay, nice.
Both.
My second question is, faster is not always better. Do you think there's a ceiling to performance for the cut rate for the cutting?
Yeah, I think that there are some challenges. Now, you often have to drop the vacuum because of how fast the cut rate is now, that you can actually get some scleral infolding, especially with the current generation systems. It's better with the newer generations, but it's still an issue. But I agree with you, faster is not always better. I'm actually dropping the cut rate now more and more, and I'm having to have more settings than I did before. You know, with the Constellation, you'd have your standard core vitrectomy, and you could just go to town. But
to think about.
It's harder with the newer systems. You need many more different settings for different things.
Mm-hmm.
Quick question. AI analytics, how soon before we get something to help train fellows?
Soon, hopefully within a year.
Tomorrow. No,
hopefully within a year. So, thank you.
Thank you. So our next speaker is Dr. Avni Finn. She'll be speaking about navigating access, cost, and real-world adoption barriers.
Thank you to the Cole team for the invitation, especially Kat, Phoebe, and Alexandra. So now that we heard about all of these amazing things on the horizon to treat our patients, I get to talk about the real world and the adoption barriers we face in the clinic. Here are my financial disclosures. So barriers to access, especially those for our patients, are often economic inequities, access to specialist care, and health literacy. And we see that in studies that economic inequities really do impact patient access to care. This is a study on diabetic retinopathy. Screening showed food insecurity, housing insecurity, and mental health concerns were associated with a lower likelihood of receiving eye care. And we see the same thing with patients with wet macular degeneration. So this was a study out of the UK, showed patients in the NHS, that were socioeconomically deprived populations had worse vision when they entered the system, but also continued to have worse outcomes even after entering the system. We also see that these factors affect patient adherence to care and follow-up. Non-English speaking and urban patients in this study had significantly higher no-show rates. Ultimately, this affects their visual outcomes because they miss injections and appointments. So understanding that disparities in care start before the retina clinic is really important because these patients are going to have lower screening rates, both for diabetic retinopathy and AMD. They're going to present to us with a later stage. We have to also understand that there are structural barriers for these patients: transportation, language, clinic proximity, scheduling burdens, and then that all of these social determinants really influence their visual outcomes. And as their providers, as their doctors, this is something that's really important for us to understand. But beyond the patients, I'm going to talk to you a little bit more about the barriers we face in providing care, and specifically focus on financial barriers and administrative barriers. So let's start with administrative barriers. So prior authorization, what is that? So it's an insurance requirement for pre-approval of treatment before reimbursement. It's really common for branded anti-VEGF agents, and many times we're required to document failure of a lower cost agent. This is often called step therapy. Many of these agreements are driven by insurance and manufacturers about what agent to use first or second. And we have studies that show us that prior authorization can result in delays in care and an increased administrative burden to practices. So this was a study by Sabine Dong and a bunch of our colleagues showed that 60% of approvals for prior authorization result in a delay in care, and this can be over a week for most patients. And the most common reason for these prior authorizations are simply a reauthorization, which we do every year for a previously utilized medication. Beyond this, we see that the median time spent to just get one prior authorization is over an hour. So these prior authorization requirements we see don't necessarily change our prescribing practices, but they do create a burden and inefficiency that affects our care for our patients. Over 95% of these prior auths are ultimately approved, but 2/3 of patients experience treatment delays. Because we're treating vision-threatening diseases, these delays are strongly associated with worse visual and anatomic outcomes. So what are some things that we can do? These are my own practical suggestions for working around prior authorizations. So I think utilizing a lower cost agent such as bevacizumab first to get anti-VEGF on board for patients who might be new to your practice or have a new onset disease that you're seeing right away, at least you can get some anti-VEGF on board. When not approved, bevacizumab can be a low cost expense for both the patient and the practice, and oftentimes insurance will approve this retrospectively when you put in language indicating the urgent nature of treatment. You can also use samples as a bridge for vision-threatening disease, and it's really important to establish a process within your practice or institution. This is not really, no one is immune to this process for prior authorizations as well as reauthorizations so that your patients don't have a lapse in treatment. Next, I want to talk about copays and help you understand this landscape. So copays, for our Medicare patients, intravitreal injections are actually billed under Medicare Part B, which is their medical benefit and not their pharmacy benefit. This means that Medicare pays 80% of the cost of the drug, and the patients are responsible for 20% of the coinsurance. So for high-cost drugs, which can be around $2,000, if patients that have Medicare alone, the cost can be anywhere from $300 to $600 per injection for these patients. When we move on to commercial insurance, so this is your working age population, it depends on the plan and can vary anywhere from $50 to $400 plus per injection. Why do these copays vary so much? So again, it depends on where the medication falls. For Medicare patients, it's under their medical benefit. It also matters if they have a secondary insurance. So a lot of patients who have Medicare plus a supplemental secondary won't have a copay, but those that don't have a secondary will. And then the eligibility of the working age population or those with commercial insurance for copay programs can often help offset that copay, which we'll talk about. And then for commercial insurance, there's often a deductible or max out-of-pocket cost, which varies among insurance plans. So there are three main options to help patients with copays. There are patient assistance programs, there are copay assistance programs, and then there's the Chronic Disease Fund or Good Days. Patient assistance programs or the Patient Foundation, this is really manufactured programs for uninsured, insured patients without coverage for a medication, or insured patients that have financial hardships. And all of these programs are often manufacturer specific, and there's certain household income criteria that patients have to meet to make each of these categories. The second program is a copay assistant program. So this is for patients with commercial insurance, and these are drug manufacturer programs that can dramatically reduce copays for your working age population. Dependent on the company, this can be about $15,000 per year that your patients can use to offset their copays. The eligibility requirements are that the patients have to be often 18 or older, have commercial insurance and not Medicare. They have to reside in the US or a US territory and have an FDA-approved indication for that medication. And then lastly, the Chronic Disease Fund or Good Days. So this is a US nonprofit foundation. It's for patients with all sorts of different life-altering chronic diseases. For retina drugs, there was a fund for neovascular or retinal vascular disease, and the funding for this ceased in January 2025. Since then, it has had sporadic funding, and we really need a better long-term solution. This was primarily used to offset the copays for our Medicare population. So again, some practical suggestions here. Really create a process within your practice for enrolling patients in copay assistance programs or Good Days at the moment that you're starting that prior authorization process. A good relationship with your sales representative can be really helpful in understanding these different programs for your patients and navigating options. Also knowing the different requirements for patients. You know, if I see Medicare and that patient has a supplement, I know that patient can oftentimes get a branded intravitreal agent. And I often start that conversation early with patients about their copays. And then I also just wanted to talk about, really importantly, how do we advocate for our patients and what else can we do to change this landscape? It's important to get involved, meet with your industry reps, understand programs available and how to support your patients. Work with the ASRS. We have different committees, the Health Economics and Practice Management Committees, the AAO and their advocacy endeavors, your local and state ophthalmologic societies, and then use research as a form of advocacy. I'm not going to go through all of these studies, but a little plug here for Sean Berkowitz, one of the Cole Fellows, who's done a lot of this work looking at cost analysis to really show and inform policymakers of the value that certain treatments and surgeries add to our patient care. So in summary, there are economic inequities and barriers to access that influence our care and ultimately visual outcomes. It's important for us all to be aware of this and help to improve these barriers for our patients. Understand the financial and administrative barriers to providing care. This is something we all deal with on a daily basis, and we need to help navigate solutions for our patients, and then continue to be an advocate for your patients and your profession. So thanks from me and Nashville's two fans.
That was a great talk, Avni. So one of the things that I think is really sobering about the talk that you gave is how much work is involved in getting prior authorizations, helping patients navigate around these increased costs. And that happens at a time where a lot of academic centers are having consolidation of sort of resources. Is that something that you've experienced at Vanderbilt? Any sort of things to note or ways to work around that?
Yeah, I think it's really important. I've worked both in private practice and in academic setting, and it's really important at a big institution to really have a strong connection with your pharmacy and also your administrators. Many times they don't really know the whole process that you're going through as a retina physician, and to help them understand what you're facing on a daily basis with communication is super important, because the more they know, the more they can really place emphasis on that and provide you with the proper resources.
Can I ask you a quick follow-up question about that? What exactly have you done to implement automatic enrollment in patient assistance programs at the time of prior auth at your institution?
Yeah, we have a pharmacy pool that basically is like a pool for retina prior auth. Every time I want to switch a drug, I will message that pool and say switching to X drug, and that automatically involves the copay team, the prior auth team, and they work to synchronously to get that authorization as well as copay enrollment.
Got it. Okay. So is there any ahead of work time like that, identify the patients coming into your clinic and have
we have
forms ready?
a pharmacy team that screens our patients ahead of time to make sure that they have authorization. That's also done. But the most important thing is actually that physician step, letting them know so that they have also done that pre-work.
Great, thank you.
Great talk, Avni. Next up, we have Hadi Kapoor, one of our graduates of the fellowship here at Cole, who's going to be talking about update on TKIs.
Thank you to the course organizers for the invitation. And thank you all for being here today for the most important talk of the night. Update on tyrosine kinase inhibitors. This is a reality in the field coming to right nowadays. We have a lot of trainees in the audience, so once you get out of training, you want to keep sure that you're updating yourself on the next things coming down the pipeline. You don't become a dinosaur and get stuck in your old ways. And if you happen to be a chairman who's busy and maybe is working on some things, you don't have a lot of time to get updates. So I'm glad you made time to make the talk tonight. So moving forward, don't be intimidated by TKIs. You're already familiar with the story of TKIs. Who here has ever done an anti-VEGF injection? VEGF is a ligand. It binds to the VEGF receptor. That's a receptor tyrosine kinase. So instead of going for the ligand, you're going for the receptor it binds to. That's all what this is. We're trying to inhibit that receptor. No disclosures financially, and everything here is not FDA-approved medication, publicly released data. So why TKIs and why now? So what's the problem? Anti-VEGF. True, it's been nothing short of a miracle for many patients. However, but we know, we've heard from Kat, from Avni as well, that the real-world outcomes don't match our trial data. They estimate about a third of patients are undertreated, leaving vision on the table. A lot of reasons for that. And those patients who do show up, maybe between 4 to 8 weeks, almost half of them are on a 4 to 8 week trial injection schedule. So they're getting a heavy burden of treatment. This all leads to treatment burden, psychological burden, getting shots in my eye every month, caregiver burden, transportation barriers on the patient side. From the doctor's perspective, your clinic is very overbooked, and you're trying to make sure you take care of all your patients. So is the solution TKI small molecules? Well, remember, we're going for receptor level inhibition, not just a ligand. So what we've been doing nowadays is just trying to soak up all the keys. And every time you put an anti-VEGF in there, you're trying to take out the keys. Now we're trying to say, let's just block the lock. That's what our TKIs are trying to do. And the nice thing here is that some of these molecules block multiple locks. So maybe we can get multiple target profiles, VEGF, PGF, c-KIT, and others. You have differential tissue penetrance and formulation flexibility, meaning we can deliver this drug to the eye in different ways and try to get different kind of bioavailability for the eye to use. Ultimately, it all comes down to increased durability with superiority outcomes. And this is important because, as we heard about step therapy from Avni just a minute ago, insurance companies feel like they can tell us how to use medications because all these new ones are non-inferior. Well, then some of these TKIs in the trials are going for superiority outcomes. So now, if a drug is labeled as superior, are they really going to be able to lock us into step therapy as much? So one of the big punchlines of tonight is the delivery system is the drug, or part of the drug, an important part of it. Why? In 2014 and 2018, there was a trial called the APEX trial for vorolanib, a TKI, that was dosed orally. So it was oral medication trying to reduce treatment burden of aflibercept. What happened? To get the medication to be bioavailable enough, you have to take a sufficient quantity of the medication where it's being absorbed in your gut and going to your liver for first pass metabolism. It caused GI and liver hepatotoxicity. So it was intolerable and was a failure. iPoint Pharmaceuticals bought the medication, and they said, you know what, we have a Duracert. If you ever heard of a Reticert, Vitracert, Iluvien, or Utiq, you're familiar with the Duracert technology. They said, let's just make one as a Rhodes, so Duracert E, and couple it with vorolanib. This medication, they're calling it Duravyu, or EYP 1901, and it's currently in phase 3 trials reporting later this year. One will report in the summer, one will report in the fall, presumably October. That's the first thing I want you to think about, bioerodible implant, lasting 6 months. The next one is a hydrogel, bioresorbable hydrogel implant. This is made by Ocular Therapeutics. It's axitinib, another TKI, plus their Elutix vehicle. This is their hydrogel. You inject it into the eyeball and into the vitreal cavity, and the eye will absorb the hydrogel over a period of time, and this will allow the medication to be slowly resolved and increase durability, known as OTX TKI, or the FDA has approved the name of Axpaxli. Clearside Biomedical, you heard about this one earlier, tried to take axitinib and put it in the suprachoroidal space. Well, it was pretty good phase 2 data. They're ready for phase 3, but they went bankrupt. So now their medication's up for sale. So if you have deep pockets, you can join the auction and try to get this suprachoroidal delivery going. Next, sub-Q. So can we inject somebody in their arm or in their leg with a TKI and try to get the same efficacy, maybe at home dosing, maybe being able to get bilateral effects instead of having to put one shot in each eyeball. Megalendronib is a medication that takes a sunitinib TKI, and that little star pattern thing right there, geodesic dome, that's the dendrimer vehicle. Basically, it's a big cage that you can bind the TKI into and allow it to not be honing into the place it's supposed to go. It's actually meant to go to activated macrophages, microglia, and hypertrophic RPE cells. So by trying to get this medication to the right place, you try to avoid systemic side effects. And lastly, people are always trying to give the patients what they want. Doctor, do you have an eye drop for me? Well, we have 2 companies trying to work on that. There's more information on the one made by Kyowa Kirin, which is tavozinib, and what they call the nanocrystallization, which is basically creating actually nanoscale 10 to minus 9 crystals in an eye drop to allow it to penetrate into the cornea and to the posterior segment. A lot of issues with this one, primarily because if you don't do these nanocrystals, what happens is you get a lot of corneal toxicity. Punctate keratopathy primarily. Cornea is really good at blocking things. So still very early data, very small patient numbers, something to watch as you come down the pipeline. Time is running out, so I'm going to go through this pretty quickly. So for Duravyu, you have a clinical program of phase 1 and phase 2 trials that showed that, you know what, between 60 to 80% of patients are finding that they can get a shot at 0.0 and at 6 months later be supplement-free or being rescue-free from aflibercept in the phase 2 trials. The phase 3 trials, like I said, Lugano and Lucia for wet AMD and Como and Capri for DME will report out, well, Lugano and Lucia will report out this year, Como and Capri will report out in the second half of 2027. Axpaxli, this actually reported out the SOL-1 study February of this year, and so it was the first phase 3 superiority endpoint for any TKI over an approved anti-VEGF, which was aflibercept in this case. We took about 344 patients, treatment naive, better than 20/80 vision, who were randomized after receiving 2 aflibercept loading doses, 2 months out, 1 month out, then they were randomized. They had to improve by 10 letters or better on ETDRS or be 20/20, which is pretty good patient population, so that's one caveat there. And could be rescued if they and they were randomized. It could be rescued if they lost 3 lines. No treatment-related side effects, so no safety signals to be worried about there. Similar, comparable to anti-VEGF. Now that it's reported out, there's a question mark that the FDA has said, and that, you know what, maybe a single trial will allow to get approval for a medication. So this company is thinking about getting submitting to the FDA. Maybe you might see that happen later this year. And here's some of the top line data here versus aflibercept. Of course, dose that this is one shot at 0.0, and then moving on to either 9 months or 1 year later, how well they did. Megalendronib, I talked about earlier. So one thing that here, they'll report new mechanistic data at this conference in 2 days. So you can go there and check out and see if you believe that the mechanism is as what they say they are. So what's the bottom line? Treatment burden is reduction, consistent and substantial across agents. Delivery platform is the main vehicle here. A lot of questions that we don't know, but we have reports later this year. Who will require the suprachoroidal injection? Will it continue? Will it die? We don't know what's going to happen. There's an open label extension for axitinib, but no one has 5-year data. So once we get more information, we'll see if it's going to do well. So thank you, and thank yourself for coming today. And don't be a dinosaur. Thank you.
Oh, I love you.
Thank you so much, Dr. Kakour. Are there any questions for Dr. Kakour on TKI?
Hadi, great overview. And I guess this question is to you and to Avni. So when we're looking at these drugs, I don't think they're going to be coming out at a discount. So how do you think this is going to impact who has access to these drugs, who's going to pay for these drugs? Because they're not going to be priced Avastin rates.
Yeah, I'll start first. So, I mean, for sure, I mean, there's a lot of questions here about even how we're going to use it in the clinic, and how we're going to deliver these, how do they fit into our current paradigm? That's the first question. Personally, I don't see these medications being something that supplants anti-VEGF, more complements it. But it's got to complement it at the right price. And so, you know, injections are decreasing reimbursements from the Medicare point of view. The money pool is getting smaller. I think it's going to be really challenging.
Yeah, I don't think we're going to see TKIs as a sole therapy for our patients, and so I think it's going to be very complicated because these patients are going to need authorization for potentially an anti-VEGF agent as well as a TKI, and I think that is a tricky situation that these companies are going to have to navigate. I think we may see more step therapy requirements in order to get us to use a TKI. And then, of course, the price point is going to be really difficult to ascertain.
Yeah, you know, it is really challenging because so often when we get a different drug, it essentially supplants the previous, you know, prior auth. And so in these cases, and with many other potential therapeutics, getting them to keep the auth for the original one, right, in that it's going to be kind of uncharted territory.
Yeah, I think from the rescue standpoint also, you might use a longer duration or duration extending drug, and then somewhere along the way it doesn't, and then you have to go back to the therapy, and that might get delayed at that point. Or they might say you're on one, you can't be on both. So it's going to take a lot of advocacy, I think, from even our standpoint to explain to insurers the importance.
And then I think the other challenge we have is we don't practice like these clinical trials. And so translating that into the real world scenario is going to be very different.
Yeah. I mean, if they can show that you're saving money in the long term, that might be something that moves the needle, but otherwise be very challenging.
Sean will have to do that for us.
Yeah. Go, Sean.
Thank you.
Thank you. Our next speaker is our illustrious chairman of COL-I, Sunil Srivastava, speaking about retinal findings in cardiovascular disease.
Thank you. I have no pictures of anybody on the panel. I just like to say that. And I created this on my own and had no AI. I had Sumit look at it, and so it got worse. Here are my financial disclosures, just revealing what I have. So as ophthalmologists, we image a lot. So last year, 130,000 images. I think Justice did most of these. Over the past 5 years, 500,000. If you think about what we do in ophthalmology, we're only second to radiology in the number of imaging tests we interpret. So I like to say ophthalmologists are radiologists with personality. We're only concentrating on ophthalmic disease. Radiology focuses on multiple disease states. But in our world, in our field, we know when we look in the eye, it is truly a window to the soul. Many things that we happen systemically have manifestations in the eye. Some of our clinical exam reveal changes, retinal features, whether it's arterial narrowing, venial widening, tortuosity. They've been all linked to cardiovascular and cerebrovascular disease. Retinal vascular caliber measurements are reproducible, they're sensitive to chronic and acute cardiovascular risks, and there are plenty of predictive models that complement some of their risk scores, but they don't replace them. So if you think right now, if any of you, many of you are young, but if you're old like me, you go to your doctor and they're going to calculate your risk of future cardiovascular disease, and they can use the atherosclerotic cardiovascular disease risk calculator. And that calculator works pretty well at predicting, we think, future disease. But there's been some really interesting studies, most of this comes from the UK, of using the UK Biobank, and using an AI-enabled retinal vasculopathy model, you can actually get very close at predicting future events from an image. And so there are many of these that have shown how quickly, with one image, you can actually predict this with imaging analysis. But really, if you think about it, where does ophthalmic imaging really fit? If you walk into an office, you're symptomatic or asymptomatic. And if you're asymptomatic, you're going to get some blood tests, hopefully a good exam. And at that point, they're going to calculate your score. So where does the fundus photo really fit here? Is it before you walk in to see this doctor? Is the goal of this to identify patients who are at risk so I can send you for the 12-month wait to go see your primary care doctor? Are we trying to replace something? I would argue what we want to do is we want to help our colleagues with defining, once they are defined low risk, high risk, and look for an endpoint to determine if they're getting better. So if you look at this right now, it really doesn't replace what we currently use. It's really a complementary tool. But I think if we used multiple images, if we looked at high-risk patients, or maybe if we asked different questions, all of a sudden this imaging becomes really important. So in many recent studies, retinal imaging changes based on what's happening systemically. It's not thought about a lot, but in this study looking at intensive blood pressure lowering, there were multiple changes that were seen on fundus photography over time. There was greater arterial caliber, increased complexity, and a reduced amount of tortuosity. That's just from blood pressure control. So that shows that some of these metrics could theoretically change. We might be able to help. One of our medical students who's here, who's matched with us in the whole lab, actually showing some really interesting stuff, looking at vascular changes after starting statins. He'll be presenting this later this week, but what's interesting is we actually see the same sort of thing when you place patients on statin. There's a change in their fundus photography. So maybe what we should be doing is helping them by looking at these changes. Who do we screen and where do we do it and with what? So to answer these questions, I would argue we need to image a lot of patients right now. We need to extract clinical data. We need to get multiple time points. And we have to have a relatively diverse population to really understand what's happening here. So at Cole, we have 26 offices. We have OCTs and fundus photos almost at every single one of them. And we're told, or we're asked, hey, why don't you guys do it? Isn't it make sense since you already have the cameras? Well, as I said, between Kat, Phoebe, Justice, and Sumit, Alex too, sorry, I forgot about Alex, all of these guys are using our cameras all the time, multiple times. We have 65 patients in a retina clinic. There's no time to do this. So maybe we need to move our cameras out of ophthalmology and move them to other places. So we started locally at Cleveland in the cardiology vascular lab. We put it in vascular ultrasound. We bought the machine. We made them give us space. We put our team in there and said, why don't we do same-day OCT, OCTA in patients who are high risk? Let's see if we learn anything here. So we started there, and in 18 months, we've imaged about 1,800 patients. We are also now in pediatric rheumatology. We're in adult rheumatology. We're about to go to oncology. We're about to go to hematology and the ERs. What are we going to learn from this stuff? So one of the first things that we've learned and identified is, for a while, there have been this thought that we can find some OCT changes that are actually predict high-risk cardiovascular patients. One of them is called ripples, retinal ischemic perivascular lesions. And this was something exciting. Hey, we as ophthalmologists can be really helpful to our cardiology and internal medicine patients. If we see this, these patients have something that are highly associated with cardiovascular disease. So we decided to look at it. One of our other students, Victor Belanda, actually wrote this paper up. It's in Ophthalmology Retina. And it turns out when you look at these patients in high-risk patients, specifically cardiovascular patients who already have known cardiovascular disease, there's really no impact of having a ripple on an OCT. Does not change your prediction of whether or not you're going to have any sort of previous cardiovascular issue, what we call MACE events. When we look at patients who have MACE and those who don't have MACE, really the biggest difference is the age, whether or not you have hypertension or diabetes, whether you're a smoker. Those are the biggest differences, not whether or not you have a ripple or not. The most interesting thing that we found actually is probably the real important thing to take away of this. When we had patients who had poor imaging quality or we couldn't get an image, we looked at their outcomes. The best predictor if you were going to have a MACE event or not is whether or not we could get a picture. If we had a bad picture on you, you had the worst outcomes. So think about that for a second. We're biased in ophthalmology. We never talk about the images we exclude. We only talk about the images we include. It actually turns out all those patients we're excluding might be the sickest ones. Maybe that's the reason we have poor images. Maybe that's the reason these patients don't do well. So you have to look at all these things continuously. When we look prospectively, as I said, we started this, now we can look at see what happens to these patients over a year. And it turns out ripples have no effect on whether or not you're going to have a MACE event in a year or not. But those with the worst imaging quality had the highest rate of MACE events, 12% versus good imaging quality with 5%. It's not statistically significant because we don't have enough events, but the trend is there, again, showing you the impact here. So the lesson so far, image quality matters, but maybe it tells us something more about the patient than we realize. Correlation does not mean causation. There's lots of new information, but we need to find ways to get this information to cardiologists so they can digest this. And really what we need to find things to answer the question, do these changes stratify the risk of events? This is going to take a lot of work. We need new software that quickly registers images from different platforms, from different types of technology. We're working on this and using an AI model, but hopefully we get to the point where we're actually able to do something like this, where we can quickly extract the information from a fundus photo, an OCT, and an OCTA, and actually provide our cardiologists, our internists, with a number that they can then use to identify the patients who are at risk. So in summary, there are retinal imaging changes which correlate with systemic vascular disease risk, but currently our metrics are not any better than traditional metrics. If we integrate retinal imaging in routine non-ophthalmology practices, I do think there's a potential for early disease detection, but it's going to take a lot of work by all of us to get these images and these cameras into the right place and to image a right number of patients. Thanks to the lab for all their work, and happy to take any questions.
Any questions for Dr. Srivastava?
Sunil, fantastic work by your group, and I think it's, the whole paradigm with AI-based image analysis, it's not what you see, it's what maybe the computer sees that you don't. So your observation about poor image quality could be part of it. Similarly, there are features that you are looking at that maybe in an unbiased analysis, it's something else. Like you're looking in the macula, the computer is looking in the upper nasal quadrant, and that's the answer. So I think there's a lot of unbiased analysis that could be done here that may be even more revealing.
Yeah, I think that, again, a lot of work, right? A lot of images that we have to get, a lot of data, making sure there isn't clues on the images that bias, as we talked about, whether the chest tube is predictive of pneumonia, not really the x-ray. So I think there are a couple of things that we have to do, but it really means getting the high quality data for this kind of stuff.
I had a quick question as well. Awesome work as always. So what do you think is contributing to their inability to get good images is a question on everybody's mind. Is it their fragility? Is it some kind of neurovascular issue with their ability to cooperate?
Yeah, yes. All those things. It could be technician related, right? It could be us, right? It could be maybe they're so sick they don't breathe. They're not breathing well enough. Sitting up into the camera is difficult. Their dry eye is so bad because of systemic vascular disease. There can be a lot of different things that are going on. Also, we're doing non-mydriatic imaging, right? So maybe it's the lights are not down enough, but maybe they're in the wheelchair and you can't get them into this. So I think the best thing for us when we saw this, and it was an aha moment of, Of course that makes sense. Yeah. It makes a complete sense, but it means that data set is something we have to really carefully look at as we talk about this, or we have to get more images to make sure we include those patients.
Yeah, a lot of patients need cardiac rehab after MACE events, so sometimes that can be maybe correlated with mobility.
Yeah, we had some other things of like looking at walking tests, how far you can walk, and whether that correlates with your imaging, and it does actually. Yeah. So which is pretty cool.
Put in the waiting room.
Awesome. Quick question.
Yeah.
So from start to finish, when they go into the cardiovascular lab, like how long does it take to get all those images?
So we're right now we were doing at least this OCT, OCTA. Okay. So just a few minutes. So not any longer. I mean, it took longer probably in some cases to explain it to them and, and to get them positioned because it's not like the cardiologists have the big space for you. They put you in the closet, like, that was, they gave away to somebody else. So you're trying to navigate wheelchairs and such. Thanks.
Great talk. And then our last talk for this session is going to be by my co-organizer, Phoebe Lynn, on uveitis masquerades.
Thank you so much, Kat. So I actually wanted to frame this in terms of cognitive errors in medicine. And this is because it's a lesson for me, these cases that I'm about to show you, as well as a lesson for the team. It turns out that most medical errors are actually not due to a lack of medical knowledge, nor due to a lack of training, as we sometimes complain about, but it's not true. It turns out they're actually due to cognitive errors in medicine. There's actually many types of cognitive errors. First, there's this one called availability or heuristic error, where like you remember that last really rare case, and so they're looking at this fluorescein angiogram. You're looking at this fluorescein angiogram. You're like, oh, those are those coin-shaped lesions. That's definitely West Nile virus. But then it actually turns out to be ocular sarcoidosis. And then there's other types of cognitive errors such as premature closure. That's your kind of very typical pattern recognition. So like you're a very experienced uveitis specialist, let's say, and you've seen a ton of ocular sarcoidosis, and you're like, that must be what it is, and then you forget that maybe they have lymphoma instead. You're kind of failing to recognize other pieces of information. There's a number of other errors as well: anchoring bias, confirmation bias, representation bias. And I really encourage you to read this really quick read. It's like a crash course in almost like medical ethics on cognitive errors in clinical decision making by Brian Mendel, one of our rheumatologists at Cleveland Clinic. So this is your typical pattern recognition. So there are benefits to pattern recognition. That's why we do it. We teach our residents pattern recognition, right? And so this is a 29-year-old woman. She has these chorioretinal pigmented scars, and adjacent to that, she has this retinal whitening. She has overlying vitritis. It's a full thickness retinal necrosis. Yes, she has toxoplasmosis. She was promptly treated, and yes, we did diagnostics as well, but she was promptly treated, and she did really great. So that's why it's beneficial. But here I'm about to show you kind of the lessons, the humility lessons here. And so this is case one. It's a 77-year-old woman who's monocular. She lost the vision in her other eye, several retinal detachment repairs there. Then she had a corneal ulcer. She can't see in that eye. And then she had decreased vision in her good eye. And this is her good eye. So she's 20/40 vision's down. She was 20/20. And she has 2+ anterior vit cell. And she was referred for toxoplasmosis because of a positive toxo IgG, but negative IgM. And she's 20/40. You can see the pigmented chorioretinal scar there. There's overlying vitritis. And she was, I'll tell you later why she was seeing an ocular oncologist, but she was, told, yeah, you have toxo. The referring doctor said you had toxo. I agree, this looks like toxo. And then she was sent back to the referring doctor and said, yeah, add Bactrim, add Durezol. They neglected to kind of mention that there were these weird gelatinous multi-shaped inferior KP in the angle. And she did great. She improved on Bactrim plus steroids. And you can see like these additional scars that popped up over time. This was now then a different retina specialist that saw her. They did do a vitreous tap this time for toxo PCR. It was negative, and in fact, negative ×2. So now we're really thinking, what's going on? So what do? We took a history. I know it's hard when you see 100 patients like our chief here. But I mean,
so, history.
Yeah, he does, or Kim does.
Yeah, Kim does.
Yeah, so then, so she had this history of a blood dyscrasia. She had a positive bone marrow biopsy for a chronic prolymphocytic T-cell leukemia. And so, yes, we had to revise the diagnosis. Could it be that she has this leukemia in her eye, rather than toxoplasmosis. And so she really diagnosed herself. She came back with horrible vision. So she was just 20/25, but then on her steroid taper, her vision dropped within 2 days to 2200. And she has this new elevated undulating mass in the, the subretinal space, and it's causing these undulations in the RPE and these multifocal exudative detachments. The RPE is kind of elevated there. And she finally agrees to do a diagnostic vitrectomy. And what do we find? We find abnormal monotypic T cells, and in fact, she has prolymphocytic T cell leukemia of the eye, not toxoplasmosis, not sympathetic ophthalmia. And the problem with this, yes, it's very rare. She did great, by the way. She's back to 2025 on anti-CD52 therapy. The oncologist finally agreed to treat her because of the eye. And the problem is she had this delaying diagnosis by a year. She had possible outcome of blindness in her only eye, and she could have died from her leukemia if we didn't prompt her to get treatment. And multiple specialists involved, the cognitive errors to avoid here, premature closure, anchoring bias, confirmation bias. Here's case 2. She's 48. She has decreased vision. She was sent for intraocular lymphoma. And so horrible vision. Autofluorescence is really striking. You have these pseudohypopians that are hyperautofluorescence, these multiple RP excrescences. She's got exudative detachments. Her vision's horrible. This is what she looks like on her OCT. And here's her differential diagnosis. Here's the referral diagnosis, lymphoma. What I didn't tell you is that this is how she looked. She had purple lips, she had red, ruddy cheeks, and she has this family history of pulmonary arterial hypertension. In fact, she was already being treated for that. She actually had her lung transplant evaluation canceled because of a presumed diagnosis of intraocular lymphoma. And so we worked with our pulmonologist, got her on kind of escalated and improved maximized therapy for her PAH, and her vision actually recovered. It improved quite a bit in the left eye all the way to 20/30, and the right eye improved as well, and she's back on the lung transplant list. Problem here, there was a delay in diagnosis of 2 years, and she could have died because she didn't get her lung transplant. And multiple ophthalmologists, multiple specialists involved in diagnosis and then eventual treatment. Here's case 3. He's 52. He has worsening nyctalopia for the past 4 months. He's a truck driver, very proud of his job, but had to stop working, even though he's 20/25. And so, we were sent, I was sent this patient. He had cancer, status post resection, was in remission. They're like, oh, he must have cancer-associated retinopathy. And so please treat him. That's what they said. Okay. So in the OCT looked relatively normal. There was some really mild, hard to detect kind of speculation of outer nuclear layer in the ellipsoid zone. But his ERGs were horrible. He had markedly reduced dark adapted, light adapted, as well as multifocal ERG. And here's his differential with the referral diagnosis, cancer-associated retinopathy. And it turns out, just additional history again, he had pancreatic cancer, status post Whipple's. And in fact, he had this superior mesenteric vein removed, replaced with graft, and he actually has, replaced with graft, and then it was actually thrombosed, and he was not absorbing any of his fat-soluble vitamins. We did check his retinol levels, and it was extremely low, so we replaced it. And his ERGs actually popped back to near normal, not normal, but improved quite a bit on the full field and the multifocal ERG, and he has xerophthalmic fundus and vitamin A deficiency. And he was actually able to go back to work when we supplemented him. Problem was there was a 1-year delay in diagnosis, and he had this kind of loss of livelihood as people were trying to figure out what to do, and there were multiple ophthalmologists involved, multiple specialists involved. So this one I'm going to whiz through for time, and she's 48, and she has decreased vision. She was sent for CSR. And she did have exudative detachments, okay? And I'll just show you her pictures. And she's got this really striking, I'll just show you the autofluorescence, hyperautofluorescence, pseudohypopians. The lesions here in kind of those amorphous hyperautofluorescent lesions along the supratemporal arcade are a little different than the other case of PAH I showed you. They're just a little bit more amorphous. They look like kind of like multifocal bests. Here are her exudative detachments on the OCT. And this is the differential diagnosis with the referral diagnosis that says CSR. And basically, she had acute exudative polymorphous vitelliform maculopathy, first described by gas, sometimes idiopathic. Well, on our insistence, we had a PET CT done for her. She was in a Kaiser Permanente system, and she had multiple positive lymph nodes despite no skin melanoma, and she had metastatic melanoma. And she actually happened to have bestrophin antibodies that we looked at for academic interest. And the problem here, delay in diagnosis of 6 months, possible visual impairment, possible mortality, because until she got her metastatic melanoma diagnosed, multiple ophthalmologists and specialists. So how do you avoid cognitive errors in medicine? So instead of the fast thinking and the pattern recognition, sometimes if things don't quite fit, Try the slow thinking method. Pause, consider alternatives, seek confirming evidence even, keep an open mind, and seek out collaborative input. Thank you so much. And this is The Thinker by August Rodin. He's been installed at the Cleveland Museum of Art for the past 100 years.
Great talk, Phoebe. I can see in the faces of some of our fellows who just took oral boards that they're wondering if the cases that they just answered actually had something else going on. So I just was wondering if you could offer like a pearl or two to some of our trainees about things that might tee you off that something else is going on.
Yeah, I mean, so you really do have to take that history. I mean, especially for these cases, you have to really just throw out, you don't want to have anchoring bias and throw out the, you want to sometimes start over again with the referring diagnosis. That's definitely something I've succumbed to, is just falling for the referring diagnosis and then sticking to that. And so that, you have to look at it with fresh eyes. That's why they're there to see you. And you have to think of both zebras and horses. You can't just think of horses. You can't just think of zebras because that was on the boards. Yes, you have to think of the don't misdiagnosis. This is why I think the oral boards are kind of important, even though people kind of hate going through the process. Kat was just an examiner for this. And, you actually have to think of the don't miss things, the things that can kill people. And then broaden it as, as kind of embarrassing. Sometimes you're like doing this workup and someone's like asking, why are you doing this? 5 doctors said I didn't need this workup. But yeah, so as embarrassing as that might be, that you have to tell them about something so different, you really have to do it, so.
Thanks. You all did great. You all did great at the boards. Everyone was fine. So we're going to, in the interest of time, we're going to go ahead and skip the break and finish up with our last 3 talks. So our next speaker is going to be Preeti Rao, who's going to be talking to us about clinical features and retinal detachment rates in patients with genetically confirmed no-block syndrome.
Well, thank you so much for having me. So quick questions for the trainees. How many of you have heard of Stickler syndrome or of a patient that you saw that had Stickler syndrome? Hands? Okay, awesome. So as you know, Stickler syndrome is a collagen disorder that has a high risk of retinal detachments, almost 50%. So identifying these patients are really important because you prophylactically treat them to reduce the risk of detachments. So I'm going to talk about a variation of Stickler's case, a syndrome called Knobloch, which is a flood of patients that are going to be coming into our clinics. So these are my financial disclosures. So Knobloch syndrome is an autosomal recessive condition, which is a mutation in the COL18 gene, which is responsible, found in basement membranes. And it's characterized by a triad of features: skull-based defects such as occipital encephalocele, high myopia, and vitreoretinal degeneration. So right now, the current literature, this was originally described by William Knobloch in 1971, and the exact prevalence is unknown. So we only have reported just greater than 100 cases since 1971. And so the largest series to date is a Saudi Arabian series of 50 patients that have mixed clinical and genetic outcomes, looking at high consanguinity patients. And about 50% of patients in this cohort had detachments. And they have shown that the single surgery success rate is low, about 36%, and the highest success rate with buccal vits. But the issue is, these studies are based on scattered case reports. These are region-based, high consanguinity, based on clinical and genetic diagnosis, and really there's no comprehensive review of these patients. So the question is how do we treat these patients? Do we treat them like Stickler syndrome because they have a higher rate of detachments? Do we need to treat them prophylactically? So we did a retrospective case review to describe the systemic and ocular features, about the clinical features of this condition, and really a look at the role of RD prophylaxis. And so this is a retrospective review of 12 centers in the US looking at genetically confirmed Knobloch syndrome, and this based on this pediatric listserv. And so these are the sites, including CHOP and Wills. And so we had a sample size of 92 eyes, and so we ended up with 36 patients, or 72 eyes, and a mean follow-up was about 5 years. And so on average, there's about kids around 8 years old, female, no history of prematurity. And so the baseline high myopia risk was about -10. We found that their systemic features, about 50% had occipital defects, so encephaloceles, skull-based defects, had intracranial abnormalities. And so the rares or features were skin-based defects, joint issues, and cardiac issues. The most common anterior segment features were iris features. So they had TIDs, they had absent of iris crypts, they had cortical cataracts, but no lens subluxation. And their posterior segment were characterized by this optically empty vitreous. And so the macula has this general kind of non-specific macular features, including macular atrophy, this tessellated posterior pole, and macular holes, which is a common feature that was reported in the Saudi Arabian series, but we didn't notice as much. The peripheral features are non-specific as well, so RPE changes, only 10 to 11% actually had lattice degeneration, which is in contrast to Stickler syndrome, where we have a high perivascular lattice status. So the retinal detachments rates were high. So overall, the retinal detachment rate was about 30% in the series. 50% presented at baseline. The other 50% happened after baseline. And on average, there's about a 17% risk over a period of 5 years of developing a detachment. And so the detachments, were in this cohort that we won't go over, but basically patients that were treated with the scleral buckle had the highest success rates, followed by buccal vit. And so the signal surgery success rate is low, 60%, but the final success rate was high, about 85%. And when we compared scleral buckles to buccal vits, scleral buckles edged out slightly in terms of success rate, as we know, as these a young cohort of patients. Now, we wanted to also look at the role of our prophylaxis. So how do we treat these eyes preemptively in reducing the risk of detachments? So 30% of these eyes were treated with prophylaxis. About 60% were treated with 360-degree laser. And what we found that in patients in eyes that had prophylaxis had a 10% risk of a retinal detachment compared to those that didn't have prophylaxis was almost 40%. This is about an 80% reduction in these eyes of a retinal detachment by treating them with prophylaxis. Now, we looked at what happens to the eyes the fellow eyes. So a patient that comes in with a retinal detachment in one eye and what happens to their other eye. So about 19 eyes had fellow eyes, no detachment, and we found that while there's a lower risk of having a detachment with no prophylaxis, this is not significant. We think the numbers are just low. So in conclusion, this was the largest US-based series of purely genetically confirmed Knobloch series. Macular hole rates were low compared to the Saudi Arabian series. We found that the retinal detachments were high, single surgery success rate was lower, and that scleral buckles tend to do a little bit better in these eyes, and that most importantly, that RD prophylaxis, whether laser or scleral buckles, reduce the risk of retinal detachments almost 80%. So this is really important with patient counseling. So it's very important to identify these patients and talk to them and talk to parents about prophylactically treating them to reduce their rate of detachments. And I just wanted to thank all of the centers that were involved in the study. Thanks.
Great talk, Preeti. I think Mary Grace, who's one of our first-year fellows, has a question.
Thank you very much. That was extremely interesting. And I was hoping that you could explain a bit about what the limitations are for the single operation success rate in these patients. Is it related to them being very young and having higher rates of PVR? And what, as individual surgeons, can we do to try to increase our personal single operation success rate for these patients?
Yeah, I think the biggest thing is their age and their vitreous. So even though they're liquefied, it's really hard to get all of it. So their risk of PVR is very high. So always the number one kind of mantra in pediatric retina care is to start with the scleral buckle. You can always go in later. So it's surprising how many PVR cases and pediatric cases actually do very well with just a buckle. So always start with the buckle. You can always go back in later, and you can see in the series, but buckles do well. So you just start with that.
Actually, I'm going to hop on that. So for Stickler syndrome patients, you'll find a lot of pediatric retina specialists that say, I always do a buccal vit because the vitreous is abnormal. And so it seems that from your series that these patients, even though they have a collagen disorder, do well with primary buccals, which I thought was really interesting.
Yeah, so I think it has to do with their COL18 mutation, because COL18 is not only found in the vitreous, but it's found in the ILM, it's found in the lens. So I think it's more of a primary retinal degeneration rather than a vitreous issue, and it's more so a retinal issue rather than vitreous. So maybe they actually have more formed vitreous than we think,
Right.
and that's why they actually do better with buccals.
Awesome.
Related with the lens, sorry, one more question. Have you found an increased risk in lens subluxation in these patients?
So in the series, no, but like internationally, yes. So they oftentimes look very marphonoid in their appearance, so they're dislocated. But it's surprisingly in our series we didn't found it, but that's definitely something that is, something to look for in these patients.
Would that change your calculation on how to treat them?
I think that when you're thinking about buccal vits, you worry about lens subluxation and what oil is going to do if that's going to come to the front of the eye. So I tend to probably also to start with the buccal.
Awesome talk.
Thank you.
And thank you for being my personal phone a friend when it comes to these cases, Preeti.
I'd like to introduce our next speaker, Dr. Tom Mendel, IRD updates.
Thanks to everybody putting this together. It's a real pleasure to be here with you all. I want to talk about something I'm pretty passionate about. I do have some disclosures. Our lab's supported by the funding agencies on the left. A PI for the Alkeus Phase 3 Stargardt trial, consultant for Insmed for their upcoming Retina and joining technology Phase 1 trial, and I have a patent with Neela Therapeutics I'll be discussing. So I'm very fortunate to be at Ohio State, where I essentially get to be the eye guy in the university-wide Gene Therapy Institute, which happens to be across the street from the largest GMP vector facility in the country. And there I get to learn from a lot of very, very smart people from around the country. And some of that work you'll see here. IRD basics, you guys know a lot of this, 400,000 patients in the United States, 5.5 million globally. It's a huge unmet need. I have over 500 patients in my practice now. I see 5 to 15 a week, and these are difficult conversations. Very bilateral, high symmetry. That's actually one of our chief diagnostic points when deciding versus other diseases. Progressive vision loss, sometimes very young. Over 220 different retinal degenerations, but there are more genes than that. Some of our panels go up to 351, and these can be associated, of course, with systemic diseases. As we heard earlier this evening, we need to make sure that we don't miss things that can kill patients. So 8 minutes is comically short to go over the IRD clinical trial update.
You can do it. You can do it.
So what I will do is instead direct you to the Foundation Fighting Blindness website. They do a fantastic job. The summary...
Is your talk over?
Yeah, it's done. I'm done. Just drop the mic.
All right, back on time.
The summary is excluding all of the AMD gene therapy clinical trials. Just IRD, there are 44 active gene therapy clinical trials for IRD. I realized very quickly I needed a team, so we provide each of our patients a customized for them list of clinical trials each time we see them. And there is only one FDA approved, although it was the first FDA approved treatment for any gene therapy in the human body. Highlights from last Thursday's FFB Retinal Therapeutics Innovation Summit, and I have no disclosures here, I'm just a fanboy. X-linked retinitis pigmentosa, Janssen barely missed by 3%, otherwise we'd already have that across the finish line. Beacon Vista trial Phase 3, it's similar to Luxturna. We should get the pivotal data later on this year. So far, so good from what they've told us, and they're using microperimetry and low luminance visual acuity. They also allow the untreated patients to have the contralateral eye treated after 12 months. And then X-linked retinoschisis, the Atsena Lighthouse trial, Phase 3, already underway. This is a really impressive trial. They have a spreading AAV, and I've met their scientists. It's really impressive. They essentially don't have to pop off the fovea as we do typically with Luxturna therapy, but rather go right around it. And they've shown 5-letter improvement in BCVA and nearly 10 in low luminance visual acuity. Dramatic improvement since they have such a nice biomarker in OCT, both with their non-human primates and now with patients. Very exciting. So after considering all of these and kind of talking about these with patients, it's important to think about broadly, how do I discuss gene therapy clinical trials with patients, whether it's for IRD or these other diseases we've talked about tonight. The biofactory doesn't work for IRD. These are structural things that we need to get to where they need to go. I think about delivery and location, approach, vector, and capacity. Are we talking about AAV or lipid nanoparticle? Things are coming down the pike. And then what actually happens once it gets in there? Not all gene therapy is the same. And it's very easy to think about it at an arm's length, but if, like me, you also direct a gene therapy lab, the devil's in the details. So I'm going to go through how to think about these. We've heard at length tonight, so I don't need to repeat where to go, intravitreal, suprachoroidal, subretinal. You have to be very careful about dose, and you have to be very careful about inflammation if you're exposing the whole eye to things, and different companies are doing that better now than in the past. Vector and capacity. This is an adeno-associated virus. It's 4.6 kb cargo. That's very important to understand because the vast majority of inherited retinal disease patients have a structural protein that's much larger than that. And this has been a major bottleneck in a lot of inherited retinal disease breakthrough. Luxturna was chosen in large part because RPE65 is tiny. And so it was very easy to package into this initial bus that we use. 20 to 30 nanometers in diameter will be important for ILM considerations. And then this is a little bit forward thinking, but not all gene therapy is the same. On the left side, gene augmentation, this is Luxturna. You're putting a donut episome of RPE65 in that case into the nucleus to be transcribed and translated with some promoter control based on cell, but largely unregulated. And so that can have some implications down the line I'll get into, versus forward thinking, how do we actually control the gene in the chromatin? And how do we have physiologic control and expression of this? So with that, I began my lab. I'm just going to show you a little bit of detail. Some of this you can get in other forums. This is Luxturna therapy, intraretinal or intraoperative OCT. We make a bleb. It feels a little heretical to pop the fovea off on purpose, but we do this very, very carefully. However, about a third of Luxturna patients started to develop pretty substantial vision-limiting atrophy of the RPE. And the jury's out. This could be, it turns out that it's not a good idea to rip a diseased retina and layer of photoreceptors off of the retinal pigment epithelium. That's somewhat of a traumatic experience. Could be a subsequent hypersensitivity, could be inflammation. And then lastly, as I mentioned, this is supraphysiologic levels of RPE65 potentially. We don't know the actual nuclear count of episomes in each one of these nucleus. And the reason I say that is because they've now had subsequent papers that suggested that the patients that had the most rapid uptick in their vision, and I saw patients go 2400 to 2040 in a month. And these little kids are jumping up on the chairs and they're asking me details about their optos, and mom's crying and I'm crying, and it's very emotional. And those are the kids that then sometimes lose their vision with RPE atrophy down the line. So with that major problem in mind, I started my lab with two fundamental questions. One, how do we deliver gene therapy without traumatically detaching or damaging the retina? And two, how do we do this without inflammation in the eye? I was a fellow for the rise and fall of Bayeview, and I heard this guy talk a lot about cells above the retina and OCT. So this is a photo of me, I think, in Ewan's OR, peeling the ILM. I woke up in the middle of the night one night and said, we should do this under air. Do a vitrectomy, peel the ILM, fill the eye with air, drop in the gene therapy directly on the exposed prepared retina, and then we can hammer it in there without detaching the retina. And then how do we do that really quickly, in the order of minutes, with a naturally occurring protein that doesn't cause its own inflammation? Insulin, which induces clathrin-coated endocytosis to rapidly sponge in the AAV on the extracellular side. This was the hopeful hypothesis down the line. We got to work doing this with Bausch & Lomb's help and our Stellaris, and they actually even sent somebody to help staff. Michael's a huge colleague. And then my good friend Sukhvinder, we started from scratch. We built a large animal OR, and after 15 years of training, I got to combine my degrees in one day, which was pretty fun. We built a pig clinic. We can do ERGs, photography, OCT, fluorescein angiography, and here's the take-home slide. Panel A, balanced salt solution. This is a mouse intravitreal injection. Panel B, the GFP AAV. So it's not fixing a disease, but if it works, you get green. Panel C, you add a little bit of insulin. Panel D, a little bit more. And when we added 30 nanograms of insulin, we had to turn down the confocal. it was a eureka moment. And we were very excited, filed a patent with OSU Nationwide Children's and Nila Therapeutics, and it was off to the races. This was the core of the data for our FFB grant and our KO8. When we put the gene therapy on with insulin and then take it away after only 30 minutes in a murine explant where we keep the retina alive in a dish, it definitely helps. And when we do the full pig surgery where I leave it on there, all you got to do is keep the cornea moist, and then you're able to pull out all of the residual AAV, leaving nothing left in the eye to cause gene therapy-associated uveitis, massively widening the therapeutic window of all gene therapy in a gene-agnostic approach, and requiring, we're seeing 100-fold less vector for the same dose with insulin assistance. We went ahead and did some quick murine studies. Yes, I see the cells above the retina, Sunil. But we did get some GFB expression, and we didn't see a lot of CME. And we have not seen a safety signal yet. We shouldn't see one here with treatment. And then forward-looking steps. The guy who sits next to me in this lab is on the cover of Nature this week with this article. So this is called prime assembly. For the first time, we can put massive, full-length script DNA into the chromatin. And he and I are now beginning. He actually got in Nature with no in vivo work, all in vitro. And my lab's better at the in vivo side. So we'll be able to get above 4.6. We're talking about ABCA4, we're talking about USH2A, we're talking about some of these big behemoth genes. And then we're going to be moving into spatial transcriptomics and disease models. I injected some RD12 mice right before I came here. Here are my references. It takes a huge team, including my wife, Catherine, who's here with us tonight. This is the clinical team and the IRD team, and then here's our lab. Happy to take questions.
Very interesting work. Any questions for Dr. Mandel?
No, fantastic talk. I appreciate your efforts. I wanted to just know that how do you control off-target influence, for example, after AAV therapy or other genome editing?
That's a great question. So it depends on which thing you're doing. So if you're talking about like which cell to control, both with where you put the needles and which technique you use, also promoter control or cell specific. If you're talking about gene editing, in a couple of weeks we'll be in Boston for your ASGCT, and what will be the theme of that meeting is in vivo editing. There are different ways of doing this. What you could do, and what we're planning on doing, is rather than putting in DNA, you can put in RNA, which has a shorter half-life, just sufficiently long enough to make the edit and then stop to prevent oncogenesis.
Thank you so much.
Nice job, Tom. Awesome.
And last but not least, we have Alex Yoon, who's going to be giving us an update on MACTEL trials and treatment.
All right, we'll try to finish off quickly. I'll try to save us some time here. So I have no financial disclosures. Sunil pays me plenty.
Yes, I do. Too much.
I'm going to talk about MACTEL type 2 tonight. This is a bilateral progressive retinal neurodegenerative disease affecting the Mueller glia and the photoreceptors. It was previously thought to be a vascular disorder, but is now thought to be primarily a neurodegenerative one. It results in progressive ellipsoid zone loss on OCT, and the visual acuity oftentimes really underestimates the functional impact on these patients. This is an example of an OCT in a patient with MACTEL type 2, and as you can see, some of the features here, the cavitations, which are loss of cells, the ILM draping of that thin ILM layer over these cavitations, the loss of the ellipsoid, and then the hyperreflectivity in the middle retinal layers. So what's the functional impact? Most of these patients come in complaining of difficulty reading, seeing the small print, and central scotomas. Their baseline reading speed is estimated to be reduced by half. And then historically, there's really no therapeutics for these patients other than those that get CNV, and then we can treat them with anti-VEGF. There's no therapy. Vision is often preserved until fairly late in the disease process, and as I've mentioned, the anatomy loss precedes the functional loss, which gives us opportunities, right? Since they don't lose function until they lose the anatomy, we may be able to intervene early with a neuroprotective agent, such as with CNTF, ciliary neurotrophic factor, which is a potent photoreceptor neuroprotectant. In preclinical studies, it's been shown to be released by Mueller glia and activates via the JAK-STAT3 pathway to promote neuronal survival and inhibit cellular apoptosis. So these models, including crush injury, optic nerve injury, light toxicity, RP models, all showed that intravitreal CNTF did slow the photoreceptor death. So the thought is, can we use this to slow down the photoreceptor loss in MACTEL? So the NT501 is an encapsulated cell therapy. The premise is, how do we get a sustained intraocular release of CNTF? This is done via RPE cells, which have been genetically modified to express CNTF. These cells are placed within an implant, which is then sutured and secured to the eye wall. Very similar to a Retisert implant. The capsule has a semi-permeable membrane, so the CNTF can be released into the vitreous cavity. There were 2 trials evaluating the use of these cellular implants. There are multi-center randomized sham-controlled trials. The primary endpoint is the rate of ellipsoid zone area loss, with key secondary endpoints being reading speed and retinal sensitivity, and then key safety secondary endpoints, severe vision loss, and treatment associated AEs. So key inclusion criteria, patients had to be diagnosed with MACTEL, aged between 21 and 80, easy break between 0.16 and 2 millimeter squared area, and then best visual acuity of 54 letters or Snellen equivalent of 20/80 or better. I won't, in the interest of time, I won't read off the exclusion criteria, but they're shown here. So the primary endpoint was met in both of these studies. There was a reduction in the ellipsoid zone loss over 2 years, 55% reduction in one study and 31% in the other. Both were statistically significant. The secondary endpoints were met in one of the 2 studies. So one of the 2 studies showed preservation of retinal sensitivity. And then similarly, reading speed was met in one of the 2 studies as well. And then safety was good. Overall, the ocular-related treatment enduring AEs were mostly mild, with the most serious AEs related to the surgery itself, not the CNTF. The CNTF-related AEs included delayed dark adaptation and miosis. The other secondary safety endpoint, severe vision loss, was similar between the sham group and the NT501 groups in both studies. So in summary, the phase 3 trials showed that the NT501 encapsulated cell therapy is effective at reducing the rate of ellipsoid zone loss in MACTEL-2 patients. Treatment was well tolerated with the serious AEs related to the surgical complications. Thank you.
Awesome talk, Alex. So at Cole, I think we're going to have access to this treatment sort of pretty soon. As you're sort of thinking about your patients, who do you think would be sort of an ideal patient like for this treatment?
So I didn't show this, but in some of the secondary analysis, I think there's some evidence that the earlier you treat, the more efficacious and the greater slowing that they saw. So if this were true, then potentially those patients who may just be experiencing some functional loss.
So, Alex, you're saying treat earlier in your mind. Do you think it's like, so for some of this is, we're making the diagnosis based on clinical exam. We're basing the diagnosis on easy changes. So as you see it, is it the 20/40 patient with early easy loss that you're treating? Or are you waiting for them to drop to 20/80 or something at that level?
So I think vision might be tough to use because a lot of these patients actually have amazingly good vision. Like that OCT that I showed, 20/25 vision. I mean, if you go by traditional, like wait till the 20/40, you're going to wait a long time.
Mm-hmm.
So I think we need different measures. I think if we're interested, perhaps we use secondary measures. I know only one of the two trials showed both retinal sensitivity and reading speed can be used, but perhaps there's other measures that we can look at.
Alex, does age influence your decision? Like a 50-year-old obviously makes a lot more sense than perhaps a 75-year-old.
Yeah, no, this is a great question because I don't think it's known kind of how the progression changes over time, whether it accelerates, in which case maybe you do have a little bit of time in a younger patient if it accelerates as they get older. I'm not sure. That's a good question. I think it'll be an interesting thing to look at.